Chairperson and panel members. My name is Dr. Marcus Molokome. I'll be presenting on behalf of the Provincial Department of Health, Free State. With me today, to my left, is Advocate Justice Finger, who's Head of Legal Services in the Department of Health, Free State. Immediately to my right, the fair lady is Mepinki Belot. She is Head of the Licensing Unit in the Free State Department of Health, the private facilities licensing. And the far right is Ndate Ruben Rieters, who's Head of Emergency Medical Services in the Free State. I will be making the presentation.
What language are you going to speak? Sotho?
I would have loved to use my mother tongue, which is Sepedi. I'm a traveler. I'm originally from Limpopo. So, and with me here, I have Ruben Rieters, Brad Didal, and then the two Basotho are, just around me. So we'll use English, Chairperson, if you allow.
Well, because you come from Limpopo, you can't speak what they speak in Freestate. You have to speak in Limpopo. What they speak in Limpopo. Okay, very well. Again, just place yourself on record, and then if you are ready to start, then we can go ahead. First of all, let's make sure that we have all the documentation that you sent to us. Okay, you can go ahead. Yeah.
Just okay. Thank you very much to the panel for the opportunity. I'm representing the Free State Department of Health. Our approach with the documents we've already delivered, we are going to focus on the summarized version of our PowerPoint presentation. So I'll be talking to the slides as we go along. I'll make the presentation to the end. The colleagues around me, as introduced, will then be of assistance if there are any questions or clarity or discussions at the end of the presentation. Our intention as the Free State is to stick within the hour or even less, if you allow, Judge or Chairperson.
Can we do this? Yeah, sure. I think what would be very helpful to us indeed would be if you can just summarize your presentation so that at least we have sufficient time for engagement. Okay? Yeah. But of course, I can't stop you from, reading your presentation. Thank you.
Thank you very much, Chairperson. We were here yesterday for, we just missed the Med scheme presentation at the end, just to get the sense of our approach so that we can save you time. So we are committed to that. It will not be 10 p.m. again. Thank you. We will basically almost stay on this content slides because we want to just give a narration of the summary that you already have. And in that way, I'm sure we'll be able to save time. We'll not go word verbatim what's on the slides. The Free State, in a nutshell, has been in the middle of the country, faces different complications or implications in terms of its geography. It is a primarily rural province, divided into 5 municipal districts. Harib district, which is more towards the south, close to the Orange River, close to the Val is Fezile Dabi. To the northwest, we have Lejwe-Leputswa. To the east is Thabo Mfutsanyane, close to where we are now. And centrally is the Mangaung Metro, which covers area from Tabanchu, Botshabelo, and Bloemfontein City. So that is the only metro we have. Our population size is, according to Stats SA, around 2.6 million for the entire province. In your presentations, you will look at the distribution of the private sector beds with all their differentials. But what is of note when you look at them, you'll see that Mediclinic group in the Free State dominates the number of beds in their different configurations. It be acute, subacute, and even some of the day beds or mental health beds that they have. Another thing that is clearing, it is how Bloemfontein is dominating the number of beds in the Free State. The Health System Trust in 2010 had a little study, and per capita we're showing that we are really competing with Gauteng in terms of private beds against the population. But the issue in the Free State is the distribution of those beds. And what we are trying to show there is that we're having the rural areas like Harib district where there's not even a single private sector bed. Thabo Mofokeng is the biggest district, but it's the poorest of all the districts. It's only now that they're starting to have a second private hospital being built in that district. So as the committee, as the private facility licensing committee, these are some of the mandates, or in our regulations. This is one of the areas that we're looking at, the distribution of the beds. It is an area that became highly contested 2 years ago, 2014, when we gazetted the Free State private facilities licensing, because there were groups, especially Health Hospital Association of South Africa, which the document we've included, that were challenging us that we are instituting Section 36, Certificate of Need, indirectly, by declaring that this committee or the committee should be looking at where these beds should be placed in terms of need. And it is at this point that I want to touch on a point that briefly was touched yesterday, that the complication of the health sector is when need and demand are mixed together, or the two terms are used interchangeably. Because demand can be created. And I can give examples. Many of us who are parents in here, or grandparents for some chairperson, you'd find that many of our children now are exposed to psychometric tests. We have now psychologists who are education specialists. In my case, my own daughter is going through occupational therapy just because of the way she holds the pen. And because she writes 8 not flowing, she writes 2 zeros put together. So that is demand. The demand is created. And we can go on and on about the attention deficit diseases that all our kids are on now. That is demand to us. It's an economical concept which can be created. It is linked to want, which can be religious, political, and so forth. We are talking need. And to us, need means we look at burden of disease. We look at what do we need to do to get people healthy, and what is available to get them to that. The difficulty with that approach that we have found in the Free State, which was maybe touched even yesterday, was that because we do not measure, and some of these things don't have signals, we end up having a problem of what is healthy. How do we define a healthy society? What is this outcome we're talking about? Is it based on usage? Is it based on head counts? How many people contact or use our services? Or is there a more community-based measurement in terms of what is healthy? So the need in itself sometimes is not an exact science. So when we talk about the need for beds, in the Free State, if you look at the statistics that we've given you in terms of the numbers, you'll see that in Bloemfontein, because it's urban in relation to the rest of the districts as a metro, you'll find that the demand is higher than the need. So invariably, you're continuously having oversupply of services because it is informed by the economy of the area. But if you go to districts like Harib, Thabo Mofokeng, you find those are the poorly serviced areas in terms of private health care because the demand is lower than the need. So invariably what you have this disjuncture between urban and rural areas, and the applications for private facilities follows the markets. So you end up having everybody applying for Bloemfontein, which is what the slides would show you that you have in terms of the numbers we've shown. Now, what we have done in 2014 was to try and reverse that by looking at what joint ventures are possible with the private sector to make sure that we service the population, not based on demand, based on need. The examples for demand and need can go on and on. I sometimes watch TV and I listen to somebody called a wallet doctor, where you get money for being admitted. So that in itself creates a demand for a bed in private sector because I can get money whilst I'm lying there. So demand can be tempered with. and we should then focus on need. And in the Free State, we maintain that's where we should be going with our regulation in terms of the private facilities. I'm going to skip the other areas. I think they're quite straightforward in terms of what we regulate. It's not too different from other provinces. But what we did add, given that what the information was telling us, was inclusion of a need for a business plan by the applicant to be included. What we had realized in the past, without having business plans, people were just applying based on demand or need. We've gone past that. But then what we ended up having at the end was that people were getting approvals, not necessarily licenses. The way it works in the Free State, we give you an approval, you get a license when you finish building, and we have inspected. So you have an approval to build, and then you get a license at the end of the term, which is according to our regulations in 3 years. Now, what used to happen is that people will get this approval but never got things off the ground because they then had financial difficulties because the planning was not what it's supposed to be. So what we had said, we said we'll now include the request for a business plan. But what we are struggling with, to be upfront with the panel and the Commission, is that, Chairperson, we do not have stringent financial instruments that we can use to measure these business plans. As you know, business plans now can be produced by the internet. You Google it, you get a template, you populate it, it looks good on paper. But sometimes it is never practical. And this is why you'll find in many of the slides, people who got approval in 2012-13, many of them are still in process. And many of them are struggling partly because of the finances. In another scenario where that really woke us up as a province was that we sometimes will then approve subacute beds for a particular area based on need. That supplier will go and turn the soil, make foundations, pay about 7-8 million. When they go to Standard Bank, for example, in this case, for more funding, Standard Bank says, we've done our own study. There's no way you can have subacute beds in that area. They should be acute beds. That's the only time we're going to give you the money. Then the supplier then reapplies for amendments of the application. So it becomes a vicious cycle where now the need is tempered with, informed by the finances. So we are maintaining that we need a proper business plan from day one that we can adhere to as something that is sustainable. Secondly, what we introduced is this community involvement, social responsibility. It used to be quite loose in terms of the way it was penned in the regulations. And many of these hospital groups would just provide CPD training for doctors and say that's our community involvement. What we have done since 2014 was that we want a plan, an annual plan. That annual plan must include things that we can measure, because if you can't measure it, it's not going to be done. And the community involvement should be clearly defined, and also the social responsibility. Not as a general, not in general terms, but it should be drilled down and customized to the communities that these hospital groups find themselves in. It needs to go beyond just CPD point training or continued professional development. I apologize for the abbreviation for doctors. It needs to be proper social development linked to the needs in that area. We even are asking for them to set milestones so that these things are time-bound in terms of the social responsibility. So the way we're interrogating applications now going forward will be that. And we want to make a humble request, Chairperson, that municipalities, maybe through SALGA, should be engaged maybe in this process, because many of the delays in the Free State are caused at that level in terms of private facilities. We give approval. Part of the process is that you must submit your plans to the municipality. The municipality must then okay the plans and give an approval. Secondly, the purchasing of the sites or the land becomes a huge delay for many of the applicants. So many of them give up at that level. And when they give up, the panel should appreciate that we give this based on need. So when things don't happen, it means we're denying people services in that area, because then a license for 3 years, nothing happens, and then after 3 years, only then do we realize, oh, this is not going to happen, then we restart the process. So it means it's 3 years of people not getting a particular service. It'd be subacute, acute or mental health. And for a province disadvantaged like the Free State, with its own geography, that where we're sharing soft borders with everybody except Limpopo, it becomes quite difficult. So we propose humbly that municipalities, maybe if there's time, can be engaged, maybe broadly through SALGA, just to check what issues are in terms of allowing people to get land. What are the issues? Is it contested lands? Is it farms that are green land and not brown? All those kind of issues. Or in terms of special planning. Sometimes the two departments, because we do not have those interactions, will approve and find that there's another plan from the municipality to do something else in that area. So I think it will be another area to complete that loop in terms of.
Has the provincial government engaged the municipalities on the issue of the delays?
Thank you, Chairperson, for the question. Not at the moment. I think we are engaging them on other matters. But when it comes to this facility licensing, since 2014 when we came on and changed the regulations, we still haven't. The other area that we know we are struggling at, and we as a province haven't moved forward, is the quality assurance wing in terms of assessing these facilities. You'll see in the documents there are different kinds of assessments. And the first assessment is that we said we will only inspect at completion of the construction. And we found problems with that approach. Because then if some people build an infection or what we call a sluice room, a dirty room, and you find that dirty room is built without an exit, so the dirty things are going to walk through the clean areas and the reception. It is difficult when you come and you discover that at opening, that no, you need to open this door. You know, there must be a door. And sometimes that is on the third floor. There is no way they're going to break that wall and create a staircase for them to be compliant. So what we are opting for going forward in reviewing our regulations is to make sure that we identify key levels in those buildings where we come in to inspect. Currently, our regulations are saying those kind of inspections are done by invitation, meaning the group must then invite us to inspect. So we want to stop making it voluntary. It must be mandatory visits by our units, maybe at foundation level, window level, and so forth, depending on how infrastructure engineers will advise us, to make sure that we correct things, because variation orders at the end are quite expensive to get people to be compliant. Also, it is sharing the information with the public. We do share the Office of Health Standard Compliance or National Core Standards, that what used to be, through our governance bodies for public sector facilities. So we have clinic committees, hospital boards, we have provincial and district health councils. That's where all this, our CEOs and district managers are held to account to the public in terms of our compliance. But with private facilities, we still haven't shared our findings. For example, a Mediclinic group would score 72%. That information invariably had always remained in the department. We would not go out and publish that Mediclinic compared to Life, Rose Park compared to Netcare, this is their scoring, compared to Ernest Oppenheimer, this is their scoring. That we haven't done. And I want to declare that up front. That is an area that we are willing to go and look at. We also need to review the penalties.
That has not been done.
No particular reason, Chairperson. I think it's been an oversight, and it is informed by, I think, in the past, the way we approach private and public sector. It's only now, I think in the past 5 years, that even the department itself is starting to call itself Freestate Health, not Freestate Department of Health. Because once you do that, you are already suggesting that demarcation between private sector and the public sector. Whereas the minister always says he's not a minister of public health. He's the Minister of Health in the country. And even our MECs should start approaching, as we are doing in the Free State Health, to approach that we are responsible for the entire system of health, not public and private. So we've been rigorous in assessing, even if you look at our outcomes, in terms of mortality rates, you'll find that we are willing to publish number of maternal deaths that happens in a particular facility in Bloemfontein. But you will not find us doing the same about Mediclinic down the road in Bloemfontein. So it's only now that we are starting to engage them. Our legal department actually next week has a meeting where we are starting that platform so that we are able to report to the public.
Is that not required by the regulations, though? That would require public institutions to report on these matters, but doesn't deal with the private sector.
Yes, our regulation and our act is focused primarily on the public sector. We are mandated, but what we have done as districts, you'll find in Lujo, you'll find when we report mortality rates, we report maternal deaths, for example, from all facilities, including our private sector. So it's been sporadic. It's not something that's been structured. And that's what we're saying as the unit that leads for licensing. We need to start on that platform to make sure there's that collaboration. But there's nothing stopping us. It is just something that was not done in reporting the public sector and the data. I'll just give a quick example. When we had that campaign by the minister in the country for HIV counseling and testing, HCT, that was the first time since I've been in the system that we have had interaction in sharing data with the private sector proper. Because when we did the mop-up, we went to the National Health Laboratory Services, NHLS, to get their data. We physically went to every practitioner to get their data on HIV counseling and testing, including male medical circumcisions. We went to all private groups, hospital groups, to get their data as part of the mop-up process. So that's why maybe at the end people claim we performed well as a country, because we, for once, had an eagle view of what the system is doing in terms of our strategies for HIV/AIDS. And those are the initiatives that I'm talking about, but we haven't built on them going forward. But this is up to now. But going forward, that's what we intend doing. Okay. Chairperson, should we continue?
Yes, please, by all means.
Kate Finger to just make one point, if you allow, Chairperson.
No, I just wanted to bring to the panel's attention that the new regulations, it's compulsory for private sector to provide us with data. So we've made it compulsory if you look at Regulation 31, the new regulations. Thanks.
Previously, it wasn't, was it? It wasn't, yes. So you had to focus on public institutions. And who was responsible for gathering this information? Was this the district council or was it the provincial government?
Provincial government. Yes, thank you. Lastly, we want to now, in terms of our assessment, the way we are assessing, I've spoken about penalties. Our penalties are 100,000 or 5 years imprisonment for non-compliance. We think that is too light. I think going forward in the way we want to take quality assurance seriously, we need to review these penalties. It's quite easy, I'm sure, for some of these hospital groups to budget 100,000 just for compliance. It will be quite easy to budget for that. So we need to look at how we're going to enforce and make that heavier. Lastly, we want to look at our assessment tools. I think our assessment tools are designed based on national cost standards. And national cost standards, for their purposes, are quite brilliant. But they measure the basic. They look at the floor, they look at how clean things are. We want to upgrade that to start looking at governance issues, to start looking at clinical governance issues. As you have heard yesterday, that sometimes even clinical notes are not what they're supposed to be. We need to start measuring those. And lastly, we need to start measuring outcomes. It be patient satisfaction and so forth. So the tool needs to be redeveloped to move beyond just the core basics.
Is there any reason why this was not done previously?
I think the reason is that our system is still growing. I won't say it's still, in immaturity. It's still growing because even in the public sector itself, we are still using national cost standards to assess ourselves. And those standards are quite basic. So if you were to just oppose our tools against other developed countries or even some other countries, Ghana in the continent, their measurements are more advanced than what we're measuring. For example, we would come to a facility and just measure if there's a policy. So we haven't transpolated that or moved that into the private sector. So what we actually even did, we didn't even have a tool. You'll find many provinces have developed their tools based on the national cost standards that we use to assess our clinics or hospitals in the public sector. It's only now that we are starting to now come up with better tools for emergency medical services, mental health institutions, because we're using just generic terms to measure, as you'll have seen in our submission to you. So it was not happening because even ourselves, we're still learning from these tools within the public sector. The Office of Health Standard Compliance itself has now, as an independent group, as I'll say, upped the game in a way, in terms of what they're measuring with their triangulation approach. Not only whether there's a policy, they'll then go and check if the policy is applied at the production site. I want to move to the second section that I think just finally is that because we haven't been approving facilities with almost all our facilities that we have standing were regulated with Regulation 158. So you'll find that going forward, we'll then have some legal battles with some of the groups in terms of applying our current regulations. Like we've submitted the HASA document indicating areas of concern that they were raising. I'm moving, Chairperson, if you allow, to the second section that I wanted to cover.
Is someone going to speak to those issues, the litigation at some point? Oh, yes, thank you.
I think I will talk to that once I just finish the summary, and we'll just touch on those areas, if you allow. Thank you. The Free State, like in its uniqueness, back in 2000 to 2002, entered into a PPP, a public-private partnership with a hospital group, Netcare. The contract is included in one of your folders there. Now, the intention of this was firstly to look at, we defined the concession period to be 16 years, which would have meant 2018 would have been the last year of this PPP. But right from its inception, it took longer than anticipated to finish the bricks and mortar building of the wings, the private wings. So there was a concession between the department and the Netcare groups through CHM to move that concession period by extra 4 years. So now it will end in 2022. Not 2018. I wanted to just clarify where that concession came from. But the principles that were on the table from the beginning were we need to have a shared services model with Netcare. And this was at two facilities, Bilinomi Tertiary Hospital and Universitas Academic Hospital, with different beds. There will be facility fees. We needed to look at a model of improved revenue collection from both sides, but primarily we needed to redirect that revenue to improve the patient experience of care in the public sector. So we needed to improve revenue collection, but that revenue collection must be translated into patient experience in the public sector. We needed to also look at efficiencies in terms of management and clinical care. But the most important one was the risk bearing. The risk needed to be transferred to the Netcare group. So those were the principles. In 2010, as shown in the document, we realized an EXCO took a resolution, Provincial Executive Committee, took a resolution that we need to interrogate this contract because we are not realizing any of those principles. And this was 8-9 years into it. We then engaged KPMG to come and be the arbiter and also continue with the audit and interrogation of this contract. The document is included in the Word document that we sent as a narrative to our presentation. What we've done there in detail, Chairperson, we've included the milestones right from day one, month by month in the Word document, what's been happening to date. What we had found was that this partnership, the risk burden rested with the department. There were disagreements with almost all the fees. We couldn't see how revenue streams were redirected to the public sector for patients to benefit. And there are many of us who were of the opinion, even though we haven't provided the evidence, that Netcare was in this partnership primarily as a comfort zone to get a license, because primarily it means they have a license till 2022. In essence, it's a partnership that we have, and if you want to exit the partnership, there are legal fees and we could be sued. So basically, Netcare is in this space. They are guaranteed a license until the concession period ends. So we all agreed that that couldn't be. We needed to go back to the principles of the PPP. But the most important part to raise here is that this was before Regulation 16. This was before Regulation 16, the Treasury. So this was happening without any legal framework in the country. So the country was not ready for any partnership of any sort, or especially of this kind. But it happened. So what we are trying to do, because we cannot sometimes apply the law retrospectively, and I'm in your hands here, Judge. If I'm not a legal eagle, but that's my understanding of the law. That
Hands are full.
Thank you, Chairperson. Now, the issue then that we have is that we needed to then interrogate, go through arbitration as in our contract, have some agreements, have some concessions. And at the moment as we speak, one of the biggest problems that we realized was, firstly, we needed to make sure we have what we call a management unit for this PPP, because of the nature of the PPP and the amount of capital or investment that we are talking about. But also we looked at the revenue streams, and we looked at the problems that, because even data collection was not what it's supposed to be, we couldn't measure things in terms of this contract. And there are those who are of the opinion that this contract really have introduced other complications. And one complication I want to touch on is the radiology billing or radiology revenue stream that also became as part of this contract. I know the RSSA, the Radiology Society of South Africa, has already presented in Pretoria. And I know they also use that popular term, price takers. But in the Free State, we have a different notion or concept and experience from radiologists. Radiologists formed a group, and through that group, they entered this PPP space to bill for radiology services on behalf of the department. So there's a contract that we've included in the pile there, in the folder. But the funny thing about this contract is that it entitled the department right from the beginning to only 33.3% of the net collections. And when we did this assessment, we all felt that this couldn't be. And I do not want to make this a legacy issue and blame people in the past. It is a matter that we needed to deal with. Because firstly, it meant all the risks rest with the Department of Health. We own the equipment. We maintain the equipment. We have the personnel. This is all the administrative people and the radiologists and the radiographers. People who are owning the company are actually our employees. But they are making 76% profit for just providing a practice number and claiming on our behalf. That's exactly what that contract entails. And we needed to put a stop to that. So what we did, HOD then issued, which is included in your archives there, to terminate and then go properly onto tender if there is a need for billing for radiology services. So I just wanted to touch on that in terms of part of the PPP. It's not in essence legally part of the PPP, but the PPP platform created an environment where such practice could happen.
Just tell me, is there a policy now that governs these PPPs?
Yes, there is now. There is that Regulation 16 I'm referring to in the Treasury and also the PFMA. But back in 1999, when this was contemplated, there was none. It was just an open land where innovative people could enter the space. And I must say, there are a lot of lessons that we learned from this PPP, and I'm sure other provinces will give their forwarding experience and so forth. But ours is quite unique, and I'll touch on the second section. I'm coming back to this point on other complications that this PPP brought.
Can I just understand, so the nature of the issue with the radiology group is that they did the billing service for the province?
Yes, there was a notion that somehow our department and Netcare were made to believe that they will not be able to charge total fees in terms of the uniform fee structure, the UPFS. So they needed a practice number from specialists to be able to bill for 100% of the fees. So that is the arrangement. So what they are providing as a group, like you heard yesterday, that is better to pay into groups. They made that kind of a group as radiologists. Once they made the group, they came out with an association which had a practice number. That practice number is the practice number that claims for all medical aid patients and private paying patients that comes to the facility. So they are basically claiming for all the services of imaging and treatment, radiological treatments in our facilities. So that money gets into their account as people who've carried out the service. But that service is not only them. They report on the images. The service is done by radiographers who are employees of the state. These people in this group also are professors and heads of departments who are radiologists within the department. So that is the arrangement, just to paint the picture. But once those monies are there, they will pay all their costs. And then 33% is due to the person or the department that owns the equipment, that pays salaries and maintains the equipment.
So the costs that are covered by the income does not include the departmental costs?
Not at all. It's just what you pay the people who do their electronic data insertion, the EDI, who send the batches, their claims. Some monies was paid as bonuses to radiographers. I think they were paying them like a stipend on top of the salaries we pay. So those are the costs, and maybe other company costs that they might experience. So it's not the cost of the state. That's why I'm saying all the risks, 100%, rested on the state. They just provided an administration and a practice number.
And was this contract signed between the Freestate Department of Health? Treasury wasn't involved at all?
Not at that point.
Provincial Treasury?
Not at all.
And how much are we talking about here?
I'll share the figures because we had asked for confidentiality, because we want to be open with the panel as much as possible, because our idea is that we need to correct things. We're not here to defend or hide anything, because we want things to be done in the correct framework. We're talking turnover of up to 18, 19 million a year. That's the turnover. So we will be entitled to around 33% of that. Let me just add, Chairperson, that this month of May is
But are you going to come back to this point at some? Are you going to come back to this issue? Yes. Now, precisely, what is it that these radiologists did, apart from supplying the practice number?
In terms of service, these are our employees. So basically, they in the daily process of giving out service, those patients that are fee paying then get billed through that vehicle. So all your patients that are on medical aid, when they interact with our service, will be billed. Let me just add where this other stream of patients came from. In our Netcare PPP arrangement, Netcare does not own any radiology capacity. So all the patients that are in Netcare at both Universitas Academic Hospital and Bilinomi Tertiary Hospital are then transferred to the public site to come and have the tests and the imaging done. So basically all the patients that ever had an X-ray, an MRI scan, a CT scan, or any contrast medium treatments from Netcare group as part of the PPP were seen in the public site, on the public site at Universitas and Bilinomi, but will have been billed by this group. Now, Netcare at some point also had some, I don't remember the percentages, also had some money that was paid from the group to Netcare as part of their revenue because of that arrangement. But Netcare will tell you this arrangement was not part of them. They are pointing the finger towards the provincial government because that's where the contract is held. But in terms of benefits, those benefits went both ways. We can call them benefits. I'm just saying the payments. And we even had a concession, Chairperson, that patients that came from Netcare would not wait when they came to the public side. So if you find 100 poor patients queuing up in radiology for a particular X-ray modality, and 3 Netcare patients arrived by the porter, those will be the first to be seen. And these are some of the things that we've been challenging because we did not want, and in one of our discussions, it's just, things sometimes don't get written down. People were saying people who don't pay don't mind waiting sometimes. And these are some of the notions that we want addressed. That's why we're saying we're here to open up in terms of our experience with our PPP so that we once and for all correct what's been going on. So to answer your question, they did nothing else. They just provided practice numbers but continued to work as they would anyway for a salary because they report on every image. That they would have been doing anyway. But the issue was that the hospital on its own couldn't be able to, I think we were allowed 30 to 35%, but don't quote me on that, we need to cross-reference. As a hospital, we could only bill for a section of the fee. But them as radiologists could get 100%. But from that 100%, we still get 30% anyway.
Help me understand this. These radiologists were employees of the provincial government. Yes. Now, and they were getting paid a salary by the provincial government.
Yes, they were. The second section, I'm not going to come back to this, the technical part, but there's another element that I want to touch on that informs how employees of the state end up doing business in this manner with the department.
Now, in addition to the salary that they will receive monthly, then they have a share of about 63%.
Yes, Chairperson. So, as the RSSA will have presented, the Radiologist Society, the radiologists are basically hospital-based. So there's always an argument that I'm a radiologist in the state. There's no way I can go do any other work outside. So my work needs to be done where I'm at. So that is another argument that's always been flighted in terms of justifying this practice. That I'm here 24/7. I'm not like another private sector radiologist who's in another hospital and getting all this money on their own. So that is another element to this angle, which is I'll touch on just now. The next concept that I want to touch on, thank you, Chairperson, is this whole concept of remunerative work outside the public service. I'm not too sure if other provinces have touched on it yet, but we want to go deep into it because to us, this is the biggest problem we face. And part of it is that the Freestate, with its PPP arrangement, has created an enabling environment, a fertile ground for this practice to happen. Basically, as you said, Chairperson, now, these are employees of the state that are now given approval to go do remunerative work where they are paid outside the public service. And outside in this case does not mean outside office hours. It means outside the premises. I want to be clear on that because sometimes people think we're saying out means it's after work, so it doesn't matter. In this case, we're talking work that's done just outside any of our premises. This is a section 30 in the DPSA. You'll find that it's by policy allowed to happen. But many provinces have their own interpretation of how to apply this concept of RWAPs, or remunerative work outside the public service. Other provinces, especially in this case where we are sitting, KwaZulu-Natal, has put an end to it in 2010. Many other provinces, we're still struggling with this beast. In terms of our arrangement, Netcare is attached to our facilities. We can be sitting here. If you go to the loo here, you're already in Netcare. That's about 3 or 4 steps. Now, if you have an arrangement with a specialist who works for Netcare and works for you, you never know where they are at. So invariably, during office hours, they're able to see their own private patients and see public sector patients. And we all know, Chairperson, that if somebody is called by Netcare and they are still seeing 10 poor people, we know where they're going to go. I think we can argue about the ethics and the behavior the whole day, but the issue is we know that sometimes this market is driven by income or money or revenues. Now it is against that we then in 2013 started the process of reviewing the policy. And what we had done was that we are not going to approve any remunerative work outside the public service where people apply to do it during office hours or during when they are on call. That is overtime. This applies to all public officials in the Free State, but we were focusing specially on clinicians. The biggest problems that we're facing, I'll tabulate them now. Number one was service delivery. We realized that people were leaving the public sector to go and work in their private rooms, in the hospital groups, or their own private practices during peak hours. By this we mean between 10 and 2 o'clock. This is when you find many patients in our outpatient departments, patients in the wards, so ward rounds were not done the way they should be, meaning we are not discharging patients as we should, and so forth, in terms of service delivery. The second part was supervision. We felt that this practice was encouraging what we call this juniorization, if there's such a word, juniorization of the doctor's sector, where you find there's no hierarchy anymore. We knew, many of us when we trade, we knew it was almost like military. There was a head of department, there were consultants, there were senior registrars, there were junior registrars, there were medical officers, seniors and junior medical officers, there were ComServe doctors, and then there were interns, in that order. So that was the pecking order. But now all that is gone murky because people are just haphazardly living at any given time, not in a structured manner. So you'll find sometimes in the services, the frontline person is not the most senior. You'll find a new registrar who's basically a medical officer, being the one running the services, because the top echelon has left the service to go do their remunerative work. So it juniorized the front line of medical care. And this has led to many litigations, especially when you find junior doctors having mishaps because they were not supervised. And we could test in some of the cases that if the senior person was there, the decisions taken or the problem list that would have been drawn or the interaction with the family or the intervention would have been more robust in identifying what's wrong and doing something about it. So this practice is now coming and showing its ugly head in litigations because the senior was not on site. We know the problem with this chairperson is that you'll not get many witnesses to this because as junior doctors, we all want to be promoted and qualify as specialists. We hardly report our seniors or they were not on site. And that's the biggest problem AROPS brings. But to me, the biggest one is the next one, training and teaching. Yesterday you were told here that some of the doctors don't write the codes. And it is our submission here that problem starts at the production line. The doctors who are producing now, and we've all been saying it in corners, we are saying it here. The doctors who are producing now in terms of quality are a far cry from what we used to produce. The specialists we produce now are a far cry from what we used to produce. Let me just give an example. If you get a good intern who's produced from a particular university, the first day they arrive, you give them an A4 paper to write clinical notes, they will complain. They will want 3 more pages to write clinical notes. But you meet the same intern when they are a medical officer. They need half of that page to write the notes. So they will be so domesticated because the hierarchy has lost its shape to a point that people get domesticated with the bad cultures within the medical sector. And AROPS is the cause of all this. In terms of training and supervision, research is suffering because the heads sometimes are not on site. Teaching is suffering because people are chasing AROPS. And this is, in 2013, is what informed our position on AROPS. We got challenged, we were taken to court, we were interdicted for technical bits in terms of creating expectation. Because this is a privilege, it's not a right. It's something that's applied for annually. And we can say yes or no. But later on, that a finger can maybe touch on the legal technical bits if you so wish, Chairperson. Now, okay.
These doctors who are supposed to train these trainee doctors, if that's the appropriate term, are they attached to tertiary institutions as well, where they teach?
Yes. The biggest problem we face with these ROPs is basically the academic facilities, because this is where you find all the super specialists and many of our specialists. In the Free State, like in many other provinces, you will not find this as a big problem in district hospitals, clinic, CH6, community health clinics or centers, or regional hospitals. That's where it starts. In regional hospitals, yes, you will find it. Your Bongani Regional Hospital, your Ditlabing in Bethlehem. But Pilunomi Regional Tertiary Hospital and universities, that's where you find the biggest problem, because most of all the applicants are from those facilities. And we are focusing on this because the biggest problem we were concerned about teaching. And we had contacted the dean because we feel, in terms of what I'm going to present now later, we feel that the universities have a key role to play, because we cannot allow teaching and research and learning to suffer, whilst we're allowing people to go and do ROPs. And then in between that is service delivery. So that was our position. It was not to tamper with any autonomy of any nature, all those things that we were accused of. But the issue, we're not here to defend our position, we're just presenting the problems we experienced. We had 50 specialists to date since 2013 left the services because of this matter.
Can I ask you this question? These professors, I assume they are professors because they are attached to tertiary institutions. Would they go and do RWAPs during the teaching hours? In other words, absent themselves from lectures because they want to go and do RWAPs?
I wouldn't say yes, but it's something we couldn't measure because of our human resources measurements are not that advanced, because people will always give you a work plan, but whether they adhere to that work plan in terms of measurements, it becomes difficult, which is why we then need the dean of the medical schools to be assessing that on their side. Because we have this space called joint appointments. So these are people who are employed by the state. We pay 70% of their salaries, and 30% comes from higher education because they are linked to the facilities, to the medical schools. So half the time when they claim I'm in an academic meeting, as CEO, I'm not too sure if I do not collaborate with the dean, if that is so. Because on my worksheet, it will say 2 till 4 academic commitments. If I'm a CEO, I will just assume they're at the university. But if I don't follow up to say, where is Professor Molokomi at this time? And be told, no, he's busy in lectures. Or sometimes you're told he's busy in his rooms, please phone his rooms. So those kind of, our HR hasn't entered that space rigorously to do those measurements.
So are you suggesting that one of the problems with WARS is with RWAPs is that it is difficult to monitor? I understand. Please say that on record.
Yes, there's a notion that RWAPs as a policy is not a problem. The problem is its monitoring, because we do not have the necessary tools to do that.
Can I just clarify with regard to the teaching commitments? There are 2 kinds of teaching, as I understand it, that happens. The one kind of teaching is lectures, and the other kind of teaching is service learning. Service learning takes place in the hospitals around the bedside. So is it the case that if doctors are not in the hospitals running their ward rounds, they are not doing their teaching?
Yes, you're absolutely correct. And that is to us, that's the most important teaching in a medical school, the academic ward round. Now, many of those ward rounds will have been given by senior registrars, because the consultants invariably will have been doing RWAPs. That's the point I was making, that we have juniorized all fronts. So an academic ward round where, as a junior doctor, you panicked and never slept the whole night, to knowing that tomorrow is an academic ward round, it's going to take an hour of rigorous learning with patients. Now it's done by junior officials because the seniors might have been out doing those ROPs. So it's two components, I agree. It is the physical, traditional lectures standing in front of the students in the medical school or research supervisions, and there's also the most important, the textbook is the patient.
Can you give us a bit more detail, please, on the court case? So you were taken to court over RWAPs, and what was the outcome?
Okay. Can I allow Justice Finger to give the detail?
The outcome was that, it was really a procedural issue because I think they raised an issue that there was not enough consultation. We had issued an instruction that RWAPs would not be allowed between 7 and 4. And they went to court and brought the whole history as to where RWAPs came from, and that it's something that they are used to, and we should have allowed a more time to consult with them, and also not just stop it immediately, give them some time to adjust, and the judge agreed with them at the time.
Said really was that you should have consulted, given them more time. It really was a procedural matter. The court did not get into the merits or the demerits of the whole exercise. Isn't that right?
That is correct. Yes.
Thank you. Now, taking it further, we always said, who are the actors in this space? Obviously, it's the clinicians themselves. But the hospital managers, in what Chairperson has raised in terms of managing and monitoring, clinical managers, heads of clinical departments and clinical units. But the problem is that many of them are involved in the scheme. So it becomes an agency issue in terms of how it should be managed. We also need to highlight that, as he's touched on the finger, the issue of RWAPs was really, as a policy, like I said, it's not a bad thing. It was to mitigate the disjuncture or the disparity between what private sector doctors were earning and what public sector doctors were earning. So it was a balancing act to allow people, and also to allow some skills. Sometimes there's some equipment we don't have in the public sector, but it's available out there. So it exposes our clinicians to both worlds, if you like, and we're supposed to benefit. Patients were supposed to benefit from that practice, but we know it hasn't happened. But in terms of monies, the specific dispensation, occupational, OSD, when it came, it basically closed that bridge. But then we just continued with RWAPs as if it was a right, not a privilege. We never assessed whether we have reached utopia. We reached a point where we've equalized what private sector doctors are earning and those doctors with us in the public sector. And there are many people who argue that we are paying, even though the salaries are not what they're supposed to be in terms of being risk-based and so forth for doctors. But by far, we've bridged that gap. Because also now, give you an example, an obstetrician, for example, for indemnity will pay up to 300,000 rand in private practice. The same obstetrician working at Pilinoma institution pays nothing because they have vicarious liability. So basically, we, in terms of costs and benefits, we have equalized what people earn. So meaning the need for RWAPs must be reviewed, and it is beyond that background that we're going to give a resolution. Deans of medical schools are the biggest player.
To this question. But there is another problem, though, isn't there? Because you must be able to attract and retain the specialist. And for you to do that, you need to offer them conditions of service with which they'll be comfortable. And wasn't RWAP supposed to address that problem partly?
Yes, partly, but in the main it was to equalize, like I said, that gap that existed. In terms of our services competing with the private sector, that's something we need to, as a province, to work on, to make sure that the goods and services are in order, the equipment is up to scratch, so that specialists are doing what they are trained to do. We do not want them to venture into private sector to go experience things. When they are sitting for tea, they should be able to compare notes in terms of what they are treating with their counterparts in the private sector. And to many of the people, even though they're complaining about RWAPs, the biggest thing that we haven't maybe addressed is to address the environment that we work in, to make sure that it attracts people on its own without having them do AROPS. And sometimes we don't want to paint everybody with the same brush. There are many clinicians that are committed in the public sector, have stayed in the sector. There are many medical officers who we even call career medical officers for maybe wrong reasons, who are those traditional doctors who just stay there and render a service, even in this melee of AROPS, and so they are not participating in that. So there are a few people that we're focusing on who are the ones that are really abusing the system. But there are many committed doctors. I don't want to leave the panel with the impression that in the Free State it is hullabaloo, people are just doing AROPS. It is a few people that we're dealing with, but it creates a problem. The second point that I wanted to make in terms of actors is the hospital groups themselves after the deans of medical schools. Because when many of these people leave to do AROPS, they are doing them in the private hospitals. So it is for the benefit of the hospitals that we allow these people to go out. Example, if I'm an anesthetist doper, like for theater, you'll find that my theater lists are booked between 10 and 1 o'clock. Then the question should be asked, shouldn't you be in the public sector hospital right now? You're running theaters here. So in the Free State, we started with Netcare now to partner because they have biometric systems to start monitoring movement of our doctors. So for cardiology department, I know at any given time which cardiologist is in there at what time, which nurses to support are in there at what time. So there is an area there to be looked at in partnership in controlling the movement of our clinicians. Lastly is the medical aids. We know GEMS started in 2013-14 to produce lists based on personal numbers and ID numbers, list of clinicians that are being paid by GEMS medical aid, whereas being employed by the state. It is a little measurement, even if it can create other problems. It is at least the beginning of knowing who is earning money from medical aids, whereas in the state. Because it then it's a proxy measurement. Because we can then even measure, if they are specialists, what time those patients were seen. Now, the hurdle that we could not jump when GEMS provided the lists was that many people were threatening to take us to court because they were claiming, well, this is an employer-employee relationship. It cannot be entered by a third party, in this case, GEMS. So I'm just putting that as one of the attempts that were out there to try and curb this abuse of AROPS. Lastly, in our proposal, we're saying we need to standardize this practice. Many provinces have different approaches. Some have actually outrightly banned AROPS. Some of us tried other means and we struggled. And we are calling that we need to standardize it in the short term. But in the long term, we need to call for a repeal of Section 30 and come up with an innovative and more inclusive method of instituting another kind of AROPS in a way, or another retention strategy. I've given one instance about magnet facilities, where we make sure that every specialist have got everything they desire to treat patients in the public sector, and we pay them well. Because at the end, this is what this is about. The last point that I wanted to make, Chairperson, then if there are any other issues, then my colleagues can come in, is...
Go ahead, yes, thank you.
The last point I want to raise, representing the Free State, is one of the experiences we have as a public sector, divided from the private sector, is that we invariably get calls to receive patients from the private hospital groups based on that the medical aid is exhausted. And we've had few meetings locally to try and address this with the hospital groups, but we're putting it here because the practice hasn't stopped. And we have put in confidence 2 cases, one from I think last year, one that's quite recent as well, about a practice where you'll find a private hospital will admit a pregnant mother. That mother gives birth to a baby with maybe a little abnormality, needing a neonatal ICU. Depending on the scheme, what they cover and what they're willing to cover, or how much savings they have, you'll find the mother is admitted in that hospital, but the baby is ferried to a public sector hospital, separating mother and the child right from day one based on money. And in the case that we're putting forward, unfortunately, the baby demised. And we're saying that can't be. Going forward, this is a space we need to look at. We expect our private hospital groups to nurse patients to wellness. And this is what the point that was made yesterday. We're not measuring outcomes. We're measuring price and affordability. Whereas in the midst of all the presentations we even had yesterday, this point was not addressed in terms of what happens when a patient lying in ICU runs out of funds. What is the obligation of the medical aid? Is it a pro rata determination? Do they have to apply for motivation? Or do you ship out this patient expecting government to now take over because now there's no money? There are many cases like this. The most other recent one that we did not include was a case from a patient from Lesotho. And this is one of the challenges that we face in the Free State with the proximities. That patient came, admitted in Mediclinic Bloemfontein, got a drug reaction, a condition she did not come with initially. Got a drug reaction, ended up in ICU. 3 weeks later, money runs out, and the family is called from Lesotho to come and collect. Now the family ends up at my office saying, please help. There's nowhere else to go. When we feel this is a practice that must be brought to an end. The other part that we want to raise is the issue of protocols. The clinical protocols that we have are not standardized. So private sector, sometimes driven by the bottom line, will do renal dialysis on a patient because the medical aid for that pensioner would allow. But they do not plan that what happens when that money runs out. Because when that same patient comes to a public sector facility, our protocols will not dialyze the pensioner. Just putting it brutally as it is. So you'll find somebody comes with all the tubes hanging, expecting to be dialyzed. And we tell them, we're not going to do it. And their argument is, oh, is it because I'm poor? But the medical aid has been dried out elsewhere. And those people will not touch that patient because that patient now has no money. And we have a lot of patients that are falling through the cracks because of the protocols, but also because of the approach from the other side. Lastly, we want to just touch, we know EMS regulations are being finalized. We are also going to form a committee to regulate our private ambulances. The issue that we are raising here with private ambulances is that we are finding, and Dr. Rietes is here to just confirm, we're finding that at an accident scene, you sometimes find that the private ambulance groups would not touch some of our patients or victims because they ask the question from the side whether you are able to pay. And that is the difficulty. We have attached a case that we have handed over to the police where there was an accident in an area called Poleru in Thabo Mofutsanyane, next to Bethlehem. And 3 of the victims were speedily taken to Hoogland Mediclinic because they were on medical aid. And the rest of the victims were left there for him and his crew in public sector to arrive. And we're saying these are some of the areas that we need to look at in terms of experience of care right from the streets, not only focus on the bigger facilities. And that's the case that we want to. And lastly, when these patients run out of medical aid, even the ambulances in those hospital groups will not carry these patients. We get phoned to come and pick up. So the practice must be looked at. And I know people are calling for regulation. Some of these things don't need regulation. Some of them just needs us to be more human. Lastly, the public EMS, maybe out of trauma from the past. If you were to be picked up on the N1 around the Free State, before you get to Pelinomi Tertiary Hospital Trauma Unit, you'll have driven past 3 private sector hospitals. And our ambulances don't even bother. They just pass those with red lights wailing, high speed to Pelinomi, because they know those patients are not going to be accepted. We do not have the evidence of how many were rejected, because, like I'm saying, it has become a culture of some sort. That if those people are poor, stepped chest around next door to Mediclinic, you drive to Pelinomi. you stand more chance of saving that life than going next door. And these are some of the practices, unfortunately, that come, and we cannot just stand here and prove that this is what's happening. Here's the evidence, because people will say we've never rejected a patient. But in our call center, we do record all these calls that we get, and some of the calls are such calls where we are requested to come and pick up, and people are declaring, please come pick up, because the patient is run out of money. Chairperson, that is almost 90% of our presentation linking with an oral submission, and I'll just check if that is our oral submission, but the panel is available to answer.
Yes, on this last issue, may I ask you this question? Does the provincial government has a policy on emergency medical care?
Yes, we do, Chairperson. We have an emergency medical services unit which covers pre-hospital transport. We have high trauma or high life support vehicles. We have disaster vehicles. And then we have the planned patient transport. These are the ones that are used for referral of patients. So these are the big buggies or big Iveco buses that you'll see transporting patients between levels of care. We also have maternity ambulances. We are one of the provinces that in 2010-2011 financial year reduced maternal mortalities by 50%. So we were the icon of Africa at that point by just instituting skilled attendants speedily by putting maternity ambulances where they should. So we have different policies for different vehicles. We also have ICU vehicles and mental health ambulances, because we always have been of the opinion that mentally challenged people, we usually call the police. In our case, we call an ambulance because that person is ill, not a criminal. So we have those policies in terms of medical care. We also have airborne medicine. So we have now in the new contract, in the past we experienced biggest problems because people couldn't fly at night because of the nature of the configuration of our service. So we have now introduced a 24/7 service, so we can fly 2 clinicians, 2 patients at once at night with our airborne medicine. Interaction with the private sector, we have a contract with Buthelezi EMS for inter-facility transfers. That we've gone out on tender on, people competed, and the preferred bidder was awarded the contract. So we have a policy on all those areas. All of them are underpinned by our referral policy and diversion policy.
Now, what is the attitude of the private sector to individuals who are in need of emergency medical treatment, such as those who get involved in serious car accidents, who might require immediate medical attention?
What we have seen is that on arrival at an accident scene or a call, if it's a call, people will always check before they come out if there's a method of payment. On an accident scene, when they arrive, there is that triage, and that triage is no more only clinical, it is also based on the ability to pay. And the case we are reporting here for Poleru indicates just that. But also when they pick up patients who are unable to pay, the same private facility ambulances that are linked to hospitals would not go to their own facilities. They would drive to public sector hospitals to go and deliver. So you'll invariably find private, and it's not unique to Freestate, you'll find private ambulances entering public facilities to drop off. And this is because they get paid from Road Accident Fund. Nothing else. I might not be able to prove it here, but we know the driver there is because they are able to claim for the trip to go drop off. But they will not go drop off that patient in a private sector for them to be stabilized. They will drop that patient. Destination is the public sector hospital, but they are able to claim for that transport. So you'll find many times accident scenes have all these cars and they are willing to transport, but they will check if you can afford the destination. So the destination is determined by your ability to pay. because the kilometers will already be claimed from road accident fund.
Has the provincial government engaged the private sector on the rendering of emergency medical care?
Yes, Chairperson, can I allow Ndati Ruben to give you a...
Thank you, Chair. I think how operationally it happens is the private facilities, being your Netcare, your ER24, they also have their own control centers, of which they advertise their call center number to be called and so forth. So the call center or call management process is not yet in a state where we centralized it, where we have only one entry point. So currently each provider receives their own calls and they dispatch their resources as basically how they receive the calls. And based on that, we don't have control of us knowing at the go that there's an accident outside on the N1. We will always be informed by them, by their call center, talking to our call center, that we need additional resources or send more vehicle support. But only when we arrive such incidents, then we'll experience that they did have capacity at that moment, but they chose not to render services to other victims.
Yes, thank you. Okay.
Thank you very much, Judge. Good morning. I read with a lot of interest. I heard with a lot of interest your presentation, and I read in a while. Thank you very much. I think I have two areas where I would like a bit of clarification. I think I understood what you said, the difference between demand and need, which is a very interesting statement you made. It's easy to make the statement to find a solution, to really find out what need is, and also part of our job is finding out whether demand is really demand, isn't it? It's part of what we do, and we both struggle in doing that. But in the application, I'm obviously talking about the licensing process. In the application, there's a number of forms and requirements. And one of them is a business plan. And I do think that that is the document in which you would like to find information on the need to establish a hospital in a particular area, district, whatever. And then I see that you have a committee. I think you are chairing the committee that on the licensing committee that meets every month and discusses the application, and amongst them also the business plan. And it's quite hard to really interrogate a business plan and see, find out what the reality on the ground is of behind these factors. Do you issue requirements, your own requirements of this business plan? So I read that you have 5 different sort of criteria by which the committee makes its call on the business plan, and ultimately advises the head of the department whether or not to lodge to give the license. Do you require these applicants themselves to make a self-assessment of all these criteria that your committee, are going to judge this by?
Okay, thank you, Chair. What is required is for the applicant to submit all the information, and what we do as the committee, we verify that information, because already we have that information at our disposal in terms of other information that would be heavy on data. But now, like the presenter said, on the issue of the business plan, they do submit, but we don't have the skill to can say, is it good enough or what?
Sympathize. I myself have, in my long life, tried to find the truth behind business plans, and it's not easy. But what I was asking is, have you considered themselves, they themselves, to ask for a self-assessment on equity, for example, on the equitable distribution between districts of beds in the Free State, or by demographics, or what are the other criteria? BE, of course, that is easier for them to ascertain themselves. You just find out who owns the thing. But actually what I'm coming at is do a real, neat assessment themselves and put that position to you instead of you yourself having to do the analysis.
No. Yeah. We have not required that.
Make life much easier, I think. Yes, sir.
Yes, thank you. What I was presenting was that this is our biggest problem in terms of business plans, and we're looking for instruments so that we can assess. But I hear what you're saying, that we should also create a criterion that people can self-assess, so that when we can then interrogate their own assessments. We appreciate the point.
Yes, it's of course I shouldn't mingle into your affairs, but on one hand it makes life easier, but it's also more predictable, I think, for parties that apply for a license to know precisely on what criteria they will be judged upon, and they can do a self-assessment and try to. It would also make life for us a bit easier, because we would understand precisely what the criteria are and how they are going to be applied, and what weighs more, what weighs less in this situation. Can I go on to the second subject, and that is also that the panel is looking into the matter of quality, of course, and quality and information on quality provided by hospitals. And primarily, of course, our mandate is to look into the private sector, but that same probably will apply to the public sector. So in your new regulation, 2014, I see under 31, section 31.3, that the head of department may request routine statistics. And in fact, the head of department has quite recently, in 2016, I think, issued a list of statistics that he or she requires. It's a list of about 8 pages with data points that these hospitals have to provide to you on a regular basis, on a monthly basis even, I think it is. This, my first question, this applies to both the public sector and the private sector.
Thank you. Yes, it does. Like we're discussing with the chairperson, in the public sector, almost all those are mandatory. There are regulations set already in terms of the clinical data sets and all the other national data sets or provincial data sets that must be reported on. So in the public sector, we're quite rigorous on that. We are now trying to transfer that mandatory or obligation or expectation to the private sector with that section 31 of our regulation.
Thank you. When reading through the list of data, for example, the maternity data is about 20, I think, items refer to maternity data and other data as well. I had the impression that these are statistics, isn't it? These are not data points that one can use to come up with meaningful quality or quality outcome measures or indicators. It's pure statistics. How many women come in this condition, that. So it's a whole list of statistics. But you cannot derive from that meaningful outcome measures. Am I correct?
Yes, you are correct. Like I mentioned, we are having a meeting next week led by our legal department to develop that section 31 further. We are meeting all the hospital groups.
This has been postponed because I saw it was intended to take place today. Maybe it takes place today somewhere else. I would be happy to be part of that as well. It's very interesting. What I'm getting at is this. Again, maybe the same sort of basic comment or question that I had before. Did you ever consider asking, and I'm referring to the private hospitals, they themselves do an assessment of their clinical quality, in the sense that you hand them 50 clinical quality indicators, which can be taken off the internet for free, plus a description how to measure them easily. It's for free. Just hand them over. So it's a bit more complex than what I say now, but just ask them to do a self-assessment on a number of pre-described, standardized quality indicators, and do that on a continued basis, maybe not every month, but every half year. And do that in a standardized way. First of all, for all private hospitals, probably starting with new licenses as a requirement for the license, but you'd probably also be able to extend that to already existing hospitals, because you refresh your requirements every year, don't you?
Not really. The only self-assessment that they did was after we trained them on the national cost standard. Then we require them to conduct the self-assessment and verify that, but not as a continuous basis. It's not the expectation currently from the department.
It would be such a good thing to start with, I think, to get the hospitals to, first of all, self-assess on a standardized format. And you can do that, I think, as a provincial authority. Secondly, to ask them to publish this information on their site, because it's very important for the public to learn, of course, what the quality is that is being provided at all these private hospitals. It's completely compliant with the National Health Act. And thirdly, to use this information as input for sort of a risk-assessed inspection. I see that you inspect these hospitals every year or every 2 years. I'm not really sure, but I read a couple of these inspection reports, and they're fine, but they're not risk oriented. It's not, they're not. People don't go, and the team doesn't go in with prior knowledge about what the outcomes of this particular hospital are, where the problems probably are, and sort of focus in on these problem areas. I'm sort of talking like a consultant to you now, after, as a panelist asking you questions. But can I have your comments on this?
I think what you are saying is true. We have not yet engaged into that. That is the way to move, I think, after this consultation. Thank you.
Thank you very much. I have no further questions. Thank you very much.
Thank you very much for your interesting presentation. My first question is around your description of, I would say, misalignment between what you've licensed and what sometimes financial institutions, a bank in this instance, would say they would lend money on. So what I'd like to know is what would be the rationale for the bank to say, you've issued a license for an acute hospital, and they would say, we would rather fund a different type of hospital. What rationale would they put forward for that?
Thank you. The discussion is never between us as a department with the banks. The banks will discuss with the applicant. But through suspicion, or when we interrogate these applications, because then we treat them as almost new applications, when we interrogate, the reasons we're finding is that they will just oppose performance in that area from other institutions against the applicants. So if the applicant is applied for day beds, I'm giving an example, and they feel there is no business or sustainable business that they can fund on that model as compared to acute. For example, I wouldn't say they've looked at Mediclinic or Netcare, but invariably I'm sure they would compare apples with apples. So they look at performance in Bloemfontein for acute beds against performance maybe in other areas or even provinces for subacute beds. In this case, it was approval for subacute beds based on our need, but when the banks entered the fray, they felt there is no business for subacute beds. But I might add that in this example that we're giving, there was also another element. There was a lot of delay in finalizing from the municipalities in terms of the plans. So what was needed as subacute beds 5 years prior, now when you wanted to build and get funding 6 years later, might have fallen off as a business model. So that was just another element. So what we are saying is that our business plan should be so solid, as we've been advised now, that whether it's tested today or in 10 years, it will still make sense. Because invariably, if we had built those subacute beds in 3 years, it means the business could have collapsed 2 years later, according to the banks. So that lack of alignment, I think we can mitigate against if we have sound business plan interrogation, either self-assessment by the applicants and also as a committee when we assess the business plan.
The problem, though, that, as a provincial administration, one assumes that your primary focus is the provision of healthcare services. You identify that in this particular area there is a need for healthcare services, and therefore it is appropriate to issue or to grant a license. But the bank have got different considerations. They look at whether it is economically viable to have a hospital there. So you have two opposing interests which might not coincide. And that is what they would look at.
Correct, Chairperson, and that is the dilemma. But like I'm saying, the only way to mitigate that is to make sure as we assess the business plan, we also have that view. Because at some point, nobody has 300-400 million lying around. They're going to need institutions at some point. So our business plan interrogation must reach that level, so that when we approve, at least we have that strong suspicion that this is sustainable.
But you should have different considerations, because for you, it's not a question of whether the provision of healthcare services in a particular area is economically viable. For you, the question is whether there is a need there, because you have a constitutional responsibility to provide those services. If they can't go to Haribe, for example, you have to go there yourself.
Yes, Chairperson, that is the point. But the point we're making is that we equally can be oblivious to those requirements by finances, even though it's not our focus, which is why we included the business plan, so that we can look at the sustainability of what people are saying, but not use it as a criterion, because that will then create other difficulties.
That's going to land you into some problems. There will be areas where you would never be able to issue a license, whereas there is a need for it, simply because it is not economically viable. And the question really is, what are the alternatives?
Yes, that is the experience in Thabo Mofokeng and Harib, which is why maybe we didn't cover it here. We talk about joint ventures. Like you correctly have said, Chairperson, if we do not open the private facility, we're going to have to go there because the need exists in those areas. So we mentioned joint ventures in that vein. That is not the Triple P in its current form, no way. But what we're talking about is joint ventures going forward to ensure that we address the need in those areas. So joint ventures in terms of a business plan. And we currently even have new applications now. People innovators we go. People who are applying now are actually even now starting to mention joint ventures. They are not applying just as single entities. They are proposing that they are willing to partner with government in those peripheral areas based on preventative models. So we're starting to see new applicants now coming, because everybody now sees that the financial institutions would not fund the demand anymore in Bloemfontein. So we are now forced into an innovative space where we need to now find those joint ventures between the private sector and the department, provincial department, sorry.
Thank you. My second question is around your PPP experience. And I think it's widely acknowledged that public facilities do struggle with billing. And so I think that your experience is useful in terms of how you try to improve your billing through your interaction with radiologists. So what I'd like to know, that you've gone through all these different steps and you've outlined your milestones here, but what have you learned specifically to billing? Would you say that your capacity to bill has improved now through this PPP experience? And if yes, in what ways has it improved?
Thank you for the question. I think our capacity as a provincial department increased in other instances. I'll start with the latent phase. I think we have proper policies now in terms of revenue collection. We appreciate that, yes, we are not for profit, but we equally are not for losses. Now, the PFMA is quite clear in terms of the responsibility of the accounting officers, CEOs and district managers in terms of revenue collection. So that is quite clear on the latent softer side of things. In terms of the practicalities, we have now appointed case managers to be able to, and it's a practice that we learned from our PPP experiences, and we last year reviewed even their job descriptions to focus on revenue. Treasury gave us money in the past 2 years in a revenue enhancement program. So what we have learned in terms of capacity is that we need to create an ambience to pay. I think if I go to Pick and Pay and there are no tills, I might as well leave my wallet in the car. I'm just going to collect and leave. But the presence of a till suggests and creates that expectation to pay. So if you go to many of our facilities, there's not even a speed point. Nobody carries cash. We expect people to pay, but we say they must give us 50 rands. Nobody walks around with that kind of money anymore. So what we've done as a Freestate, we're even engaging service providers to come and supply us with this Aircon cards, where you can swipe a jet card, a sales house card. There's no sales house, sorry, anymore. Okay, but you'll understand, Chairperson. Sales house, Edgar's, yes. Edgar's and all those Truworths cards as methods of payment. So we're creating expectation that even though the service is for public, we need to still pay our 20 rands. We still need to pay our 10 rands. There's actually in the province a move now to even take the model, the Cuban model, where we, even though the service is free, we put how much it costs. So the people can appreciate it's free, but it has cost the state 20 rand for me to be here today. So sometimes when you come next time, you wonder, hey, I've cost the state 100 rand already, I'm not going to go. So we're creating those expectations in terms of the practicalities of revenue. We are now in the process of advertising a new tender for these revenue services based on our experiences. So the contract will be very different from where we are at. So we are terminating the current radiologist contract. This is its last month. In June, we're running the bidding processes. In July, we'll start with a new service provider based on all regulations currently, because now we're in a very nice regulatory space than where we were years ago. In terms of the PPP in 2022, there are two options. It's either there are three options actually. The immediate option is that we pay the exit, as you'll have seen in the 206 million, I think, and then we'll be sued, litigation costs maybe another 200 million, so we can pay around 400 million and end up with immediately tomorrow a hospital with equipment with 210 beds. It costs up to 2-3 million to build each bed in a hospital. So meaning, if we wanted to build an equivalent hospital in Bloemfontein, it will cost us 2 billion. So some people argue, pay the 400 million, get out of this PPP, count your losses. You have the equipment, you have a new hospital at half the price. That is the one approach. There are some who are saying, let's sit out the concession to 2022, benefit from without paying the 400 million, and don't get a service provider, absorb those beds into the system and move on. There are those who are saying the third option is to clean up our act, get the regulatory framework, bid, get people to tender for those beds and move forward. So the department still has those decisions to make in terms of lessons learned. In terms of the PPP beyond radiology services with revenue streams, yes, there are lessons to be learned on how we channel now that money towards the benefit of the public, which is the principle that underpinned this triple pay arrangement. So we do not have capacity for radiology yet. That's why we're going out on tender. But based on new regulations, new setup, new contract, new monitoring and evaluation, new data sets, and so forth.
As a government, these are the sort of services that you will be providing for the rest of your existence. Now, it does seem to everyone that perhaps it is high time that the government should reconsider outsourcing these things and develop the capacity to do these things. This process was in time to have had a transference of skills so that you train your own people to be able to do these things. These are not people from Mars who are doing this. These are ordinary human beings. And you can train them and make sure that they perform this task rather than relying always on service providers to come and do the job that civil servants are supposed to be doing. Shouldn't that be the long-term plan?
Thank you, Chairperson. In principle, yes. But in these highly specialized areas, unfortunately, the principle doesn't hold. In this, what we are outsourcing is this arrangement where we'll be able to claim 100% of the radiology fees. It is just maybe unfortunate that when the society delivered their submission in Pretoria, maybe this point was not highlighted. We were told when we engaged this group that actually there are now a set of rules that came from the society. Dadefinga is here to elaborate on that, which protected radiologists in terms of this kind of claims and profit sharing mechanisms. So even when people say they're price takers, there are many other arrangements that are not being declared in essence. And in the Free State, that's what we are experiencing. So what we are outsourcing is not the revenue collection. It is the mechanism to collect that money, because that capacity we will never have until we change our regulations in terms of our medical aid scheme rules, in terms of who can claim what and who can claim 100%. If we allow our public hospitals, for example, in this strata of patients from age 0 to age 4, to be able to claim 100% from our fee structures, then we do not need to outsource anything because the capacity exists. But the challenge becomes in the specialized areas.
What prevents you from doing that? Are the rules? It is the rules. And you made the rules.
As government, yes, we make the rules.
Then you can't blame anyone else then. Because you make the rules. And you change the rules if the rules don't work out.
I agree to the principle. The practicality is the difficulty.
So finally on this revenue, you mentioned GEMS. And when GEMS came to present to us, on many of their options, the state is the designated service provider for the PMBs. So I'd like to know if your capacity to bill, how is your capacity to bill in that area?
Our capacity to bill in terms of now the set targets for public sector patients, that includes those lower schemes in GEMS and motor health and metropolitan and so forth. Like I said, we went, 3 years ago we started a project and we have capacity in all facilities to claim for all those. We also have the assistance of MediCredit. Also many of our facilities use Meditech system for batching purposes. So in terms of claiming for patients that we see according to our strata in terms of who pays, who doesn't pay, and also those that are paying over the counter, the capacity exists in terms of meeting those targets. In the Free State, one of our challenges now that you're touching on revenue is those patients that are coming from Lesotho. But we have identified the referral pattern We've engaged 3 months ago with the Lesotho Government Department of Health, and of all the monies that we've owed, up to 60% already has been paid in those 3 months.
Thank you. My final question is on the human resources, how you assess them during your licensing and renewal of license. So on page 6 of your written submission, you have about 5 criteria that you've outlined. So I'd like you to talk more on that, in particular how you deal with assessing nursing staff for relicensing.
On the issue of the HR, we first looked at whether do they have the policies and procedures that guide the process, because we believe that the facility cannot function well if they are not having staff. And also we'll be looking into the staffing norms, especially in the nursing areas. So they will be explaining that. So we'll be monitoring what they are informing us against what will be assessing on the day of inspection, like to check how many personnel versus the number of patients, because mostly they'll be working on the acuity system to say they reallocate staff according to the acuity. And also on the issue of the the job descriptions, the issues of the PDMS, we're all looking into all those things. Not only the nursing staff personnel, but the entire facility. I don't know if I've answered.
So given the challenges you've outlined on RWAMs, have you explored using the opportunity to for relicensing as one avenue to manage the challenges you have with RWAMs?
We haven't at this juncture. What we're doing, we're engaging them outside the licensing framework, because what we had realized is that there's an opportunity there to engage the managers of these private facilities, hence the meeting that we're even supposed to have today. We wanted to start from there. I think the approach in the Free State is that we always try to find common ground. If we fail, then we'll legislate in terms of including it as part of our protocol. But what we are finding now going forward is that with the people who left the services, RWAPS is starting to become more controllable, because, like I said, we lost up to 50, just on the training platform, up to 50 specialists over the 3 years since we started controlling this space. But yes, we'll take the point that going forward, we might need to look at that as part of our human resources control in terms of relicensing.
Thank you.
Thanks very much. Yesterday we heard from Dr. Ruff. He was presenting an alternative model. And part of what you've been dealing with is the licensing of hospitals. And he presented a model which suggested that, in fact, one could license something that was a service provision that wasn't a hospital, that was a group of people who provided primary and referral services. And it seems to me that part of the issue around business plans and Standard Bank and all these things have to do with the viability, the economic viability of a hospital. And we've also heard evidence of our entire system being too hospice-centric. So is there the space, the possibility to meet need through a model that isn't licensing a hospital? And is that something that your provincial department could imagine?
Thank you. Yes. Let me give 2 examples to clarify. We are currently now, we had advertised, because it's a specialized area chairperson, regenerative medicine as an alternative to all this invasive treatments that we render. So this is not a hospital, but this is a group of service providers that are specialists in that area that we want to contract to come and provide a service. Now pay them as a group. We are one of the provinces that started 5 years ago for circumcision, where we said we will contract IPAs, for example, not individual practitioners. We needed them to organize themselves either into companies if they couldn't operate as an IPA, because an IPA is more of a relationship, or create IPAs as form of a team per area, per region. And Mutusi IPA, to give an example, was one of the IPAs that became a model for the country in terms of how we contract for services for male medical circumcision. They'll then place a claim, and what we had attached there is all the requirements in terms of quality assurance, adverse events management, in terms of outcomes and follow-up for patients, and then we'll pay on that basis. So we'll pay it once we have ticked all those boxes in terms of outcomes, but paying them as an organized group. We are now, the MEC in his budget speech this year mentioned that we need to look at triaging service as a service that we can look at having groups to assist the department to reduce the waiting times in our casualties, especially for preventative care, so that patients don't wait in a tertiary hospital, because patients don't honor or respect referral lines. You see a hospital, you come in if you are ill. So we need to have that kind of filter to provide a service at a low cost, obviously, to try and engage. So we've looked at those mechanisms. At the moment in the Free State, we're having two groups. We have an academic group where it's a group of specialists that organize themselves. And those groups are the ones that engage in terms of clinical care in the province, will be the groups. Those people who are doing AROPS, many of them are participants into those groups, because to get an approval for AROPS, you should, if you are a solo practitioner, just on that basis, we do not approve, even if you're going to do after hours, because it means the practice out there depends on you solely. If there's no one else, you're going to have to escape to go and see patients. But if it's a group practice or a team, then we know there are other people who are representing you. The radiologists also will formalize themselves into a group, even though the model is not what it's supposed to be. But it answers that question in terms of there are groups already in the Free State that are interacting with the department, not necessarily through licensing, but through them organizing themselves as specialists. What we need to then do is to make sure that those interactions are proper.
So it seems to me that you've identified many of your own problems, and you've also showed stewardship in terms of trying to move to learning from the problems, working out what might work better, and so on. And you've indicated some interventions to us where you know that something could be of assistance. So, for example, a national approach to RWAPs is the one example you gave us. Now, we are a panel who has to advise on the private sector, and my question to you is, what else do you need from, where could we be of assistance to you in, given that we're looking at the private sector, in increasing access to quality care? What do you need, or what can we, in your conception of what we're able to do, what can we provide in addition to this example of a national approach to RWAPs?
Thank you. The way the health system has been operating, obviously, has been that segregation between private and public. And I understand the principles of the NHI, universal coverage and so forth. But currently, we are working in a system that remains separate. I think the first thing would be to make sure that we share data. I think that is the first thing that we need to address, because like we had yesterday morning, that without that data, we cannot measure things. We do not know where we are at. We definitely would not know the before and the after. So I think the first thing is to share that. The second thing is alignment in processes in terms of predetermined objectives. Sometimes when we engage with private facilities. For example, in media liaison, I'm just giving an example, you'll find that the private sector will always say, hold on, we do not account to you. So there's already that kind of spooky stories about who's who. There's territorialism in terms of operating within the health system. I think one of the things that we still haven't covered here is the role of the universities in the Free State. And I'm of the opinion there's a lot of interaction of the health market with the universities that we need to look at. In this case, in the particular in the Free State, I'm talking about all the clinical trials that get carried out in our universities, all the drug tests that gets carried out in our universities. And lastly, as a Free State, where you can assist us is sometimes the behavior of the pharmaceutical companies, because it is always portrayed as the Free State as a collapsed system because there are no medications. But there are many instances, even though we haven't brought the presentation or the proof, but we are interrogating the systems, where you find companies are setting credit limits, some things that are unheard of in the public sector. A credit limit of 1 million for a province. You are basically asking that province not to have medication because a credit limit of that. So those are the kind of strategic, broad issues that I feel the Commission can assist us in interrogating and correcting going forward.
Let me understand. Are you saying that the tests that are done in clinical trials land up being to the account of the public sector?
The arrangements usually, you'll find the university holds the account. So the research monies or all those tests of monies that come from the private sector end up at the universities. And in the Free State, you'd find the Department of Health has no view or has no oversight over such. So those monies remain in control of the medical faculties. And that's what I'm highlighting.
But does the medical faculty then pay those laboratory tests that are done in clinical trials, or does the public sector pick up the cost?
The public sector, some of those, you remember that some of those, not some of those, patients or anything that happens in the medical schools, 70% of that usually happens in the public sector. We are the ones who own the hospitals. So the patients are in the hospitals, the professors and many of the clinicians are on joint appointments, so we are paying them. So the activities that they do within that space, there should be that component that comes to the public sector. That is our view as a Free State, and that's what we, within the memorandum of understanding, we're starting to interrogate. So I'm not too sure in other provinces how this pans out, how those monies gets treated once they are in the accounts of the universities. But in our case, those monies sometimes are used to appoint officials on behalf of the university, or sometimes a ward just get painted from those monies. So we're saying, and this to be explored in terms of monies that are coming in the space, but that remaining stuck at the universities.
No, I do understand what you're saying, but what I don't understand is, so I mean, I know the way clinical trials work, I understand the way hospitals work. A doctor's doing a clinical trial and he's paid for that by the pharmaceutical industry usually, or whatever, device industry, whatever's being tested. And the patients are admitted as per protocol. I come in, I'm an ordinary patient, but I'm also eligible for the trial, so I'm entered in the trial. I'm sitting in the hospital and I need X and Y test. So that legitimately be tried. But for the clinical trial, I also have test A, B, and C. For test A, B, and C, is that paid for by the university from the clinical trial funds, or is that paid for by the public sector?
That is the issue we're interrogating, because by protocol, those fees should be carried by the research fund. But what we're interrogating now is to check if our own NHLS bill doesn't end up on the public account. So that's why we haven't presented it here yet, because we didn't want to come here with wishy-washy we wanted, but we're saying it's something to be looked at. In answering your question earlier.
And then just explain to me about the 1 million rand credit limit. So if I understand you correctly, you're saying I'm a pharmaceutical and I'll say to you, okay, I'm ready to deliver, but you haven't paid me, so I'm not delivering.
Yes, even though that bill might be 15 days old, if it's close to 1 million, we cannot order with you. So once you set a credit limit, you are basically saying it's COD. And now 1 million for the whole province becomes a challenge. So what I'm saying is that hasn't happened before, and it's something that's happened from a particular company. And the engagement is that we cannot operate in that kind of space. All our bills have 30-day turnaround time. If we pay in 2 days, fine, but we have 30 days. Now, if you set a credit limit and one batch of order is 920,000, it means for that month I will not be receiving much from you, regardless of what you supply, if it is an essential drug or not. So we're saying that space also needs to be looked at. Also, taking it further, sometimes accounts get frozen without knowledge. Even though you find we've paid for all the ARVs, but we owe maybe one batch for Panado. The practice has always been the pharmaceuticals will sometimes withhold their deliveries. So it's a space that needs to be explored and looked at how some of those scenarios do happen. But the credit limit one is the one that stands out because it's happened just this year, and it's something we've never seen before, especially for a province. If it's 1 million for one facility, how do you understand? But if you're one of the biggest suppliers, and then you set a credit limit of 1 million, you are basically saying that province, every 30 days, only has 1 million to order. And that becomes a problem.
So this is an interesting scenario because my sense is that people need to sell their products. And one of the biggest consumers of ARVs anyway is the public sector. So my feeling is they need you more than you need them, unless they're the sole provider. So if they're the sole provider, more power. If you've got the money, you've got more power. So how come the free market works sometimes but not other times when it comes to government?
I heard yesterday, I'm making a point, and yes, it's a funny sector because the general principle is that the one with the gold sets the rules. But sometimes in the health sector, that equation doesn't work. And this is one of those instances where a sole provider who decides to set a credit limit, you are basically the hostage. But we're interrogating that. But what we're saying is that as a matter of principle, this is not how the public or private health sector should interact with public.
Thank you very much for the presentation. I just wanted to, you made reference to national cost standards, and you basically say you're proposing that they be made tougher. Is that more or less what you?
Not necessarily tougher, but they need to be escalated to look at things that are more beyond basic.
Now, how have your hospitals performed in at least with the most recent assessment by the Office of Health Standards Compliance?
Public service hospital. Yes, we had one West Hospital in Diamond in Harip. It's a district hospital. The way the system works, it's divided in the extreme measures. Those measures are the measures that must have. You can't fail those. So we've had one facility that failed, which is almost west in the country, Diamond District Hospital. The other hospitals are almost there, but they've regressed, like the big ones. Universitas used to be #1 in the country in the cost standards, but they've regressed to around 70% in the Office of Health Standard Compliance. But the issues that were raised are developmental issues that can be sorted out, like old aging infrastructure that can be addressed. So in terms of health, we also regressed. So as a province, we have moved from being #3 in the country to #5 with the current assessments, now talking broadly. as the entire country. But in terms of ideal clinics, as part of those assessments, 10 of the clinics that were enrolled, all of them are doing very well. 2 of them are in the top 5 primary healthcare clinics.
How would you what would you like to tell us? Because it's public knowledge that media is usually not kind in reporting on the performance of your health services in your province. You've touched on the drug issue for one, but how would you explain this? Is it fair coverage or there's room to improve?
Firstly, I think as a team here, let me be the first to declare that there is areas that we need to improve on as a health system, as a public health system, and also in private. But many of the reports that we get, they are targeted at a particular individual, who is our MEC, Dr. Malakwan. And many cases, both criminal and otherwise, have been opened against him by these groups that are protesting and feeding the information to the media. So I'll say many of the reports haven't been accurate. And even innocent scenarios have been highlighted or sensationalized. I mean, if a lift breaks down in the Itlabeng Hospital, just as an example in Bethlehem, and a picture of EMS officials is taking them carrying a stretcher of patient up the stairs, and it is portrayed as no exception to the rule. This is how things work in the Free State. You can see the sensational. If lifts don't work, we use the stairs. It is as simple as that. But unfortunately, sometimes the way it's been portrayed, it is been pitched to represent a system that is collapsing. Yes, we face challenges. Like I said, we lost 50 specialists. I mean, no system loses that as an academic platform and doesn't get shaken up. But we've equally recruited 250 registrars, that most of them are in this year. So as these problems come, like in any health system, we are mitigating for. I think the biggest problem is that we haven't told our stories as well, because I don't think we are in the business of reacting to media reports. But I think we need to start telling our stories, because there are many stories from the Free State that we should be telling in terms of the successes as the health system, also private and public.
Just on this point, isn't that okay? I'd be keen to know why the loss of so many specialists at the same time, and where did you lose them to, and whether the replacements you're talking about, registrars, which suggests, of course, these are still doctors in training, whether that doesn't explain much of the juniorization you're talking about. I'm aware of the issues, because I'm not disregarding what you said about juniorization. I'm just saying, does this not contribute to that as well?
Yes, it compounds the problem. I think to start from where we started losing specialists, I think the issue of AROPS, when we tackled it, it created that toxic environment where many of the established specialists felt they rather leave the service into private practice. Many of them are now returning to do sessions, because now I think we've removed the toxic part. I think we've managed to engage after the court ruling. We've managed to share ideas on how this would work. So many of them are returning, and many have left the services but have entered the university fray. So part of the monies that I'm talking about is those monies that parachuted them into lectureship. So we haven't lost them totally from the service. So in terms of lecturing and practicals and bedside teaching, many of them still remained, but they've left their posts as heads of clinical departments. So that was the scenario. But there are those who totally left and went to the Western Cape. That was our biggest losses, to Stellenbosch. There are many that just retired, took early retirements. They felt this is too much for them, and they rather go and be on a farm. So that those we have allowed as well. So in terms of juniorization, yes, it's compounded by the fact that we do not have the most senior people applying for posts. I think the other biggest problem the Free State faces is that when we advertise, City Press, Sunday Times, our last advert was 2 weeks ago, we hardly get how do I put it, quality people applying. You get a few chances. But that is the problem that we have, which is why we're calling for an innovative way of looking at AROPs so that we can dangle that carrot for people to come down to Mangaung. And also cheetahs are not doing too well, so that's another problem.
It was Gauteng who said they lost knock of Chilis, if I'm not mistaken, and in no time people started coming back again. And we heard yesterday, and it has been coming up now and then, that there actually maybe the private sector there is an oversupply of specialists. Now, if you have such an issue about ARWAPs, I'm just asking here your personal opinion. Isn't that maybe the one way to sort of clean up and say, okay, those who want to go, go. We will suffer in the short term, but the private sector can't absorb all of those who go. But when they come back on our terms. Would that work?
That was not our plan, but invariably it did work because sometimes you have to anticipate this unintended consequences and celebrate them. Because we never had a doubt. We knew when we started that anyways, some of these colleagues, when we say AROPs, they're not necessarily doing clinical care out there. Some of them are on the farms, some are having game farms. I can give a long list. So when they leave, they're not necessarily in another clinic. They are doing something else. So when you remove them from clinical care, they are bound to come back because what they are doing out there is not sustainable. It's not what they are trained to do. It's not what they enjoy. It's leisure. So people cannot do leisure 100%. Maybe at some point you can, but it has brought back a lot of people who are now not willing to do AROPs anymore. They appreciate our approach. And it has, in a way, cleaned out the nest, in a way. But there are those few that still remains because they knew they had nowhere else to go because it's so saturated out there that they would not survive. But also this indemnity thing is pushing people out of specialties back into the systems because it costs you 400,000 to practice, even though you're part-time. Just to see 2 patients a day, to pay 400,000 a year so that you are adequately covered. But when you work for the state, you have that comfort. So many people are coming on that basis because out there is that difficult. I think lastly, as a Free State, our focus has always been, we have shifted to super specialties, and it goes back to that issue of demand. We have created demand for super specialties. So we train fellows, almost we can compete even with Gauteng, just with one university. Remember, we have one medical school. But we train so many fellows, and it goes back to that point of demand and need. Do we really need? So we've trained, people are super specialists and they can't survive out there because you sit there and wait for a gastroenterologist patient the whole day and hardly ever see anybody. So people are now forced, because we train them so much that they can only work in the services. But it has its own negatives as well that we didn't bring here.
Yeah, still on ARWAPs. You say you've got a system that's working with the cardiologists in terms of biometrics. For me, it seems like a critical step in stabilizing in the short term. Is there a reason that it's not deployed widely? And do your employment contracts provide for that, specifically the biometrics?
Not at the moment. It's something we're exploring through our IT effort as a province to look at how we can institute beyond biometrics all the HR measurements, not only for doctors, but for all staff. We've had a presentation recently on lean management that showed that actually most of our staff works in 30% to 40% on core business. The rest of the time is either I'm visiting the next office, or I'm on the corridor, or I'm in the loo, and so forth. So we want to introduce proper human resource measurements, because if you do that, AROPS then becomes a component of that. We didn't want to just say people must check in and out and focus on as if it's a witch hunt for clinicians. We want HR measurements from security services, cleaners, up to the top specialists, because Labor Relations Act is for everybody. It does not recognize specialties.
Towards the end now, when, I mean, as a preamble to this case, was it you starting to take a leaf out of the KZN book to withdraw Arab's privileges?
That was not our approach. We benchmarked, we spoken to KwaZulu-Natal with their approach, and we knew that approach wouldn't work in the Free State for a number of reasons. In KwaZulu-Natal, they have more specialists per capita than us in the private and also in the public. Their production and retention is better than all provinces. What they produce, they keep, because they measure the return on investment with registrars. We do not. So we knew that we were going to have challenges if we approach it in that manner. We did not have the critical numbers or the critical mass to suddenly wake up and say no more Arabs. So we decided the only way we can do it is to write to all officers who are doing Arabs to say, going forward in 2013, we will not approve anybody who's applying to do them during office hours, 7:30 to 4. We will only approve from 4 p.m. till the next morning, unless you are on call. We will also not include Arabs, because some of the specialists or medical officers will have been on call that night. So we didn't want to allow that moonlighting arrangement. That was the base. That was the initial point, and that's on that basis we're taken to court.
I think Advocate said it was on a technicality that you lost. What does it mean? Is it still back on your agenda?
Yeah, and this is where sometimes we take forever as government to approve. Look, the mandate from the MEC is that we still should pursue the change of the policy to reflect that we only approve from 4 upwards. But I can tell you practically that is what we are doing currently, and I think generally being accepted, although it's not policy yet, but that is what we are doing currently, only approving after hours.
How far is the litigation concerning the regulations of 2014?
The matter is sitting in July, so that is the first time that. So we've closed all pleadings. It will be sitting in July.
Get that?
The matter will be heard in July, coming month.
Court, the High Court or the Supreme Court?
That is the High Court, Freestate High Court, yes.
What are the implications for the regulations? Does it mean you can't apply those until the court order, until the matter is resolved by the court?
No, we have not been interdicted from applying the regulations, so we are applying them. Yes, and I think you had made reference to, maybe just to briefly highlight what are the issues there. I think the main issue, HASA felt that, with regard to Section 36, they thought that is where we're coming from. That was our enabling act, but we were able to prove that actually we have our own hospital act. So they were coming from the point of view that they were able to make national department, almost believe that Section 36 is unconstitutional. That is their view. So therefore, because they were able to convince the national department, who are we to come up with our own regulations. They also felt that 2 critical issues, we shouldn't issue licenses for a year. Because they were saying it's not good for business, that there's uncertainty. But I mean, we felt that health is a critical issue, we should be able to assess each year and issue a license. And indeed, if you comply, there shouldn't be any uncertainty. The issue is compliance. If you comply, there shouldn't be uncertainty. They also felt that when there's a change of ownership, because this is one thing that we try to avoid, that you come as Justice Finger, 100% black owned. After we give you a license, then you go to someone else. So they also felt that for a change of ownership, you should just issue license once and not come when there's a change of ownership. So currently in our regulations, the license is not transferable. So as and when you dilute shares and change, you need to come as a new application. So they also did not want that. So overall, they basically accusing us of not having listened to all these matters that they raised, and that's why they're asking for a review.
I mean, as I understand, the main thrust of the challenge it is that there wasn't any proper consultation before these regulations were promulgated. That's one of the challenges.
Yes, and we've been able to prove that, in fact, there were some changes that we made subsequent to the it's just that, they felt that everything must agree with everything, but yes.
But one doesn't know what the court is going to say. It may set aside the regulations, in which even you have to start the process all over again. Okay. Now, and this was in terms of the Free State Health Act, which was promulgated, was enacted in 1996, is it?
Yes, it's the Free State Hospitals Act, 1996, yes.
What is the situation in the Free State now in relation to the licenses? You've got the Free State Act of 1996. Then you have Regulation 158, which was promulgated under the 1957 Act. Okay. Then you have the Free State Regulations of 2014. And you also have the Free State Act of 1996. Are all these measures responsible for the issuing of the licenses?
Correct, Chairperson, except that we no longer applying our Regulation R158. We basically now using the Free State Health Establishment 2014.
But that only relates to the regulations that you made in 2014, only relates to the facilities.
That is correct.
Though to try and rationalize this legislation so that you have one set of regulations that govern, hospital facilities. But you still have to wait for the High Court decision.
Actually, I think there are two acts that you've mentioned. It's the Free State Health Act, but that was in 2009. But the ones that specifically focus on hospitals is the Free State Hospitals Act of 1996, which I can tell you that we are starting to review that, to make sure that it's modern, because it's been almost 20 years that it was there. But yes, the Free State Health Act, the regulations were issued in terms of that act. Yes.
You are familiar with the regulations, are you? The regulations? Now, well, perhaps before I get there, there are two groups of licenses that I want to talk about. The first group, it's the 10 licenses which were issued but where nothing has happened. And then there are 9 licenses which were issued but which have since lapsed. So you've got a total of about 19 licenses which have been issued between 2012 and 2014, I think it is between 2008 and 2014. Were any of these licenses issued under the new regulations?
No, all of them were issued in terms of the old R158.
Now, with regard to those licenses that are not operational, what is the situation there? For how long is the situation going to continue?
I think those that are not functional, others they are within their time frames because they would have applied for the extension, most of the submission of the building plans based on the whether finances or the rezoning. But I think in particular there are two, per se that I think they have, would say their time frames that I think the department, we need to close that. Although we are saying that, but I think to make sure that they don't come back, we need to say, not senior movement, we are just to inform them officially that the application have lapsed. There are only 2 from those.
Does it concern you though that you've got licenses that were issued, that were granted in 2012, which in relation to which there's no building has commenced?
Thank you, Chairperson. Yes, it is a concern covered earlier. This is where the municipalities get into the space, because many of these applicants are able to prove that they've submitted, their paperwork is still stuck with the municipalities, or the rezoning or the land requisition still hasn't happened. And that's where we're finding the challenge. We, in the regulations, give them an extension, but some of them then end up being caught up by the regulations in terms of time. So it is a concern, yes, because we issue them, like I said, they're based on need. So if any delay we have means we haven't created that access.
Is the position that in relation to these 10 licenses that have been issued during the period 2012-2013, all of these licenses, nothing is operational because of the need to go through the approval system, all of them?
Not all of them. I think in the narrative, in the Word document, we've singled out one in Mangau Metro, where we basically have previously disadvantaged owners, and those are the ones that are also struggling in terms of the financial model. This is one of the reasons why we, in the new regulations or with the business plan interrogation, we're saying we need to tighten the belt there so that we do not allow people through that will struggle as much as those 10 that are in terms of finances. If it is the municipal, then we must go and engage with the municipalities to check what the issues are. It is a concern.
Now, I mean, does it concern you, though, that if there are these licenses that have been issued but where nothing is operational, somebody else could have been issued with that license and could have had a hospital up and running by now?
Oh yes, we agree, Chairperson, which is why the other point that we need to tighten is the penalties and also the inspections, because those regulations that issued these licenses were quite loose in terms of when we inspect. So we're inspecting by invitation or when you complete building. So meaning somebody can sit with an approval till the last day of the regulations allowing, even though they never ever had an intention or capacity to build anything. So what we are doing now in terms of inspections is to introduce site visits to check if there's anything tangible happening so that we are able to revoke a license or an approval on that basis. So we are going to set milestones to be able to check. Unlike wait, it's not going to happen, because then that's another 3 years. That's 6 years where that need has not been fulfilled.
For those licensees who are having difficulty securing the approval of their building plans or the transfer of the land, what assistance is the provincial government giving to those individuals?
At the moment, we are not in that space. All we do is await for them to bring the plans according to the regulations time frame, and then our infrastructure then interacts with those plans. So we do not offer any assistance at the moment.
What space are you talking about? You say you're not in this. What is the space that you're talking about?
Okay, well, thank you. The municipal arrangement with the applicant, because the applicant submit the plans to the municipality. They make the request to transfer the lands with the municipality and the rezoning. So that's the space I'm talking about. So that arrangement we're not in. We only then receive the approvals from the municipality.
Shouldn't the provincial government, though, try and take steps to facilitate the process of the consideration and the approval of the building plans so that you could fulfill your responsibility to make sure that health services are available within the province?
I agree we should. It's something we should look at.
The regulations contemplate there will be a committee which will be dealing with some of these issues. That committee has been set up?
Yes, I chair that committee.
One of the functions of this committee is, among other things, to oversee compliance with prescribed norms and standards, as well as the quality of services that's provided by these facilities. Have you commenced with these duties?
I think it would be the inspections that we conduct. That's when we monitor the norms and standards, where the team will have to be determined to conduct such.
What norms and standards are you using?
We are referring to the private facility tool, and norms and standards, it would be like the infection control, the health and safety, all those other related policies attached to the patient safety.
And these norms and standards?
No, it would be our annexure. I think it is attached that it will that is being revised when there's a need to review it on an annual basis if there is some gaps.
When you monitor the quality of services, precisely what is it that you're looking for? How do you
We are looking into all the processes, like the governance issues, the HR issues, the clinical issues, up to the support services, the pharmacy, all the areas, maintenance. We are looking into all these areas, how the equipment is being maintained under the healthcare technology. So each and every section is being allocated an assessor with a specialty attached that so they will follow what is required in the tool.
Do you assess the quality of the treatment that the patient receives at these private institutions?
Yes, when we do that's how we monitor whether the patient has been appropriately taken care of, starting from the admission. That's where we'll get the challenge of the clinical records, because we would not see if we would not make the decision whether the treatment that the patient is getting is based on the proper assessment, initial assessment by the doctor. Yes, we do look into that. Patient records review. We review, we analyze, we look at the records. Patient records. Yes, randomly we select the file. We'll ask for randomly the patient files. Yes, in retrospect.
Now, the regulations require these facilities, that is the private facilities, to keep these to keep records relating to the treatment and admission of patients. Is that right? Yeah.
Yes, it is, Chairperson.
And they are required to keep this, what, for 5 years, I think?
There's a differential in terms of the kind of records. For pediatrics, on childbirth is up to 18 years. Other occupational and TBs can go up to 25 to 30 years. So there is, in the national prescription, all those differentials.
What is the rationale for them to keep this record? Is it to make them available for inspection in case you need them?
Yes, firstly, it's just for clinical governance in terms of being able to do audits and research and also evidence-based medicine going forward. But also there's a legal component, because if you do not keep, any person born today can show up within the 18 years to query the treatment they received. And for occupational is the same. So there are many other acts that enter this space and inform how the record should be kept.
In terms of regulation 31, I think it is 31.1, every private health establishment shall ensure that written record relating to treatment of each patient are kept appropriately. And then it goes on to say each private establishment shall retain a copy of the records described in this regulation for 5 years from the date of the service of the patient. And then in case of a minor, it's for 3 years after the minor has attained maturity. So they are only required to keep them for 5 years.
That is correct. That is the time that we thought, it's reasonable, because we can't keep them forever, especially for adults. Yes.
And thereafter they can destroy them.
No, the expectation is that they should be archiving them according to the national prescription. But for the purposes of our audits, we expect them to keep them for this prescribed periods. That's what we capture in there.
But don't you think that it would be helpful for the provincial government if these records are kept, and there's a record of how many patients are being treated at these facilities, the kind of treatment they're getting, so that you can assess the outcomes that you're talking about?
Yes, I think the struggle here, I agree. The struggle here with the 5 and 3 years was for the purposes of these assessments. But the expectation is that the hospitals themselves, the private facilities, must comply with all the other prescriptions of archiving of the clinical records. So for the purposes of this process, what we are saying is that we can ask for any record within those time frames for us to do an audit, a clinical audit.
Now, is there a central place where all the records of these facilities are kept so that they can be accessible?
Not with us. Each facility have got their own archiving arrangement. Some have more electronic-based health records, but for such things as consent to treatment and so forth, we expect them, or prescriptions, we expect them to archive those and keep them, as we say in the Act, in the regulation.
You have told us today that you're going to do this or do that to improve the system. Now, when did this occur to you? Today?
No, Chairperson. Since we got into this, is what you are looking at in front is almost 60% of the committee. So what 2014? These are some of the things we found on the table, and we've been interrogating systems, interviewing people, and even past panel members to identify these challenges and address them. As an advisory committee, we can only submit to the head of the department for him to then make policies, where possible, to make other circulars for other public facilities, and also engagement with other already licensed private facilities. So as a committee, we are putting forward here from the minutes of our meetings where we're saying this should be that. So it's not something that happened overnight. Nothing didn't happen last night. We didn't even sleep.
Why not?
In anticipation for today. We needed to be fresh and early.
The beach is not too far from here. I can understand why you didn't sleep. No, you were here, were you not, when Dr. Is it Raf? I think it is. Yeah, where he made a presentation describing what would be the ideal, health system, and also describing where we are and how we can get to the ideal system. Now, has the provincial government had the occasion to do that exercise? Look at the healthcare system that you have in your province. Okay. Look at what you are required to provide, which is set out clearly in the Constitution, and consider how you might meet your constitutional mandate.
Yes, thank you, Chairperson. Yes, this is what we do as a department. We are constantly reviewing how we run the system. One of the main things that we introduced, it's been 4 years now, is the use of the balance scorecard to measure our performance. And the balance scorecard, as we know, coming from the kind of economic or financial setup, really asks those questions of managers in the public sector to behave as if there is a profit to be made. So what we are doing is to assess ourselves constantly on evidence-based practice and evidence-based management. The biggest problem that we identified is data management and the use of it in decision-making. And we found that as a province, we've always been struggling in terms of not just having it, just from capturing its quality, the infrastructure to make sure, and its archiving, and then its availability in terms of decision-making. With having a pilot site, Thabo Mofutshanyane NHI pilot site, we have started quite a number of projects and quite a number of tests. So to us, Thabo Mofutshanyane is both a symbol and a laboratory. So we are able to put it up as an NHI pilot site as a symbol, but also as our biggest and most poorest and vast, but also look at it as a laboratory in terms of testing all the systems that are needed. So we're not waiting for it to finish its pilotness or pilotship. We want to implement as an ongoing concern in all other provinces. Let me give 2 quick examples. We first started with a referral pattern, and we learned lessons from there. We secondly went with connectivity in terms of IT connectivity. We implemented health information management systems. Even now, with what Dr. Ralph was delivering yesterday, we looked at financing models in terms of partnerships with private practitioners. And we are now engaging with the private practitioners to see how we can get them into the system on a capitation setup, not a fee for service. It was interesting that in one of the models that was put in terms of the role of the state, what I didn't see, and I'm not here to punch any holes in any presentation, that's not what I'm here for, is that all other areas were touched, but the issue of pricing and the financing was not highlighted as where the state must come in. And we are of the opinion, with the experience that we've had in Thabo Mofokeng, that that is where the state needs to be at, because part of the NHI is to protect against catastrophe. So we agree with many of the things that we've seen. Many of those are things that we are battling with in terms of our role as the private facility licensing unit. But we have a model of where we've been and where we're going. Finally, we have produced a service transformation plan, which then starts to look at the issues of need in terms of private and public beds, ICUs and so forth, and how we can transform what we already have. So we're not only looking at building new things, how we can make what we have work.
A couple of questions ago, I asked you about the need to have the information stored. You know, one of your concerns now that you are now articulating is your inability to collect data, store it, and have it accessible to make the kind of assessment that you require to be made. But you've got the regulation. They do that, but they don't do that.
One of the, having set regulations is one thing. I think also the business model in the department had to be looked at, because in terms of
you're complaining about the fact that you don't have the data, collection of the data, which would enable you to make this kind of assessment. So what I'm saying to you, if you had made provision in your regulation for the collection of data and its storage, that would have been helpful. That's what I'm saying.
Yes, I agree.
The problem of attracting and retaining specialists, it's a major problem. Is that right?
Okay. Yes, it is.
How are you going to manage that?
The problem we face is obviously the geography, not being, a metropolis. But in terms of our training platform, we have deliberately expanded many of the numbers in terms of training. But whilst we're training, we need to link and align that training to the available posts. So the intention is to, even though people will be a bit junior, is to recruit from our own timber, like what we produce. Because the Free State, like I said, competes with many medical schools in production of specialists, even as just one university. The problem has been we're even failing to retain those that we produce. So it's two balls that we need to juggle and balance. Firstly, we're losing the aging population, or people are a bit irritated with the way we want to manage RWAPs. But this side, we are producing good quality and high numbers. So we need to now transfer those into those posts. But the issue with where the Free State is based is there have always been issues, because many of the problem has always been people want to stay in Bloemfontein and not go to Harry Smith.
One of the criteria that's set out in the regulations for which you apply when you consider licenses is the need to promote high quality services which are accessible, affordable, cost effective and safe. How do you address the issue of affordability?
The issue of affordability, remember, Chairperson, once we set these regulations, we sometimes also, in our minds, triple P arrangement that we hold with Netcare. Even though it doesn't finally influence the final outcome or the final what we put in. The issue of affordability here, what we're saying is that there will not be those catastrophes where what we are mentioning now, where patients are now dumped into the public sector. We still don't have a tool of measuring and penalizing people for that, which is why we're saying we need to relook at our penalties framework. Like we had yesterday, failures should be recognized in the market and dealt with, and that is the framework we're talking about. So there's no particular way of measuring affordability, but we cannot expect to allow hospitals to continue to dump patients in the way they are doing based on funds, because that is the affordability we're talking about.
You mentioned a joint venture, in order to encourage the establishment of health facilities in what is considered to be less economically viable areas. Have you had any one of those joint ventures so far?
At the moment, we have a proposal in Lijweleputswa, where an old, dilapidated mine hospital with up to 450 beds, there's an offer for a private sector supplier to renovate the whole building and apply for a license for about 150 of those beds. And the rest of them, we should enter them as a joint venture, because in that area we have no facility. So those are the proposals that we have now. But before we've learned from the wounds of the past that we're not going to jump into lock, stock, and barrel in such arrangements without proper regulatory frameworks.
What is contemplated is that the provincial government, will enter into a joint venture with the private sector to provide those facilities.
Correct, Chairperson.
Do you consider that to be a better alternative to triple Ps?
Correct, Chairperson. In the current regulated space, we believe we'll be able to meet all those principles that should inform any arrangement, either a joint venture or some sort of triple P.
Is there any precedent for this in any province?
Not necessarily. What we've looked at our own experience. We've looked at Folating in Gauteng, and then we're looking at all those models and see if we can find a hybrid of those, because there's some good and bad. So we need to learn from both those ones. But there's no particular model where we can go and learn that this is how it's done, because we also, from yesterday, all those regional innovations should be looked at. So that's why we're not going to jump into it without learning the lessons.
Is there anything else that you want to tell us, which you had come to tell us about, but which you have not had the opportunity to tell us about?
No, except to just say thank you very much for the opportunity to allow the Free State Provincial Health Department to come and present as honestly and openly as they can.
No, we need to thank you too for your generosity in coming and share with us the experiences of the Free State Provincial Government. But of course, one should mention that this is not the end of the engagement. We anticipate that there may be a need going into the future to probe some of these issues more closely than we have done, given the limited time that we've had with each other. Thank you to members of your team. Thank you so much. Thank you. Is the Limpopo provincial government here? Yes. I wonder, would you come forward, please, if you don't mind? We've just, well, good day, gentlemen. We are running behind schedule. Would it be convenient at this stage for us just to take a 15-minute tea break whilst you are settling into your seats, and then we will come back and then listen to your presentation? Would that be okay?
Good day, Chairperson, and if you could just lay out the approach of the presentation so that when you come back, we run with it. We don't mind for 15 minutes break.
I think what we have, you have given us quite an extensive oral presentation, and we have considered it, and we would simply request you to highlight the key points of your presentation. But of course, I have no intention of restricting what you want to say to us. But whatever you say, just bear in mind that we have had a look at it, and you need just to highlight that. But again, to tell us whatever you want to tell us. Is it clear to you?
Chairperson, it's clear. Like as I was suggesting that as you break for 15 minutes, we'll quickly look at few highlights here and there, and then that is it.
A break and then resume the hearing. Thank you. Well, good afternoon, then, gentlemen. I wonder, could you do us this favor, place yourself on record, and if you could just indicate to us who is with you and who's going to make the main presentation.
Good afternoon, Chairperson and the team. I'm Dr. Peter Gapole, currently acting head of department in Limpopo. I'm here, let me immediately start from my left-hand side. I'm with Dr. Thabo Pingwane. He's acting Chief Director, District Health Services. This is the unit or cluster which is in charge of district hospitals in Limpopo, and even what we call regional and specialized hospitals in the total of 38 hospitals. And then immediately on my right-hand side is DDG, Deputy Director General for Healthcare in general in Limpopo. That means it includes the cluster here and the programs like HIV and AIDS and TB and others. And then further, more on the right-hand side, I've got the advocate, PJ Ramotopo. He's in charge of development of memoranda of understanding in the department, mostly again any other disputes which may come through any entity, private entity in the department. The last one, Mr. Ramolai, he is Deputy Director in Infrastructure. Technically, he is leading the team when we are doing inspections in terms of checking whether, the technical part of building, it's well done. Chairperson, this is what actually I can introduce the group in, that it's an amorphous team in terms of we have taken one or two from the two teams in Limpopo which are currently doing the processing of, applying for permission to plan, erect, and finally operate. In Limpopo, licensing is the last part of the whole process, Chairperson. I thank you.
Thank you. Who's going to lead the presentation?
Sorry, Chairperson, the person, myself, who introduced the team, like I was saying, I'm currently acting HOD. And before I was requested to act as a head of department, I've been chairing the adjudication part in the committee. So I am going to lead, and the colleagues now and then, as I've introduced them, they've been playing, part in the processing. So I'll now and then, through your permission, invite one of them to deliberate more. Thanks.
Thank you very much indeed. I wonder if you could just, if you could just spell your surname, just for the record.
My surname is spelled in this way: K-G-A-P-H-O-L-E. Gapole. In Nguni, you would call it Ngambule.
You are in KZN, shall we call you Kambule?
Indeed, Chairperson, I'm in Rome.
Thank you so much indeed. Housekeeping matter. we've got this presentation which I've just found on my desk, and then there is a presentation that was sent to us some time ago. Are you going to make use of the one that's just been presented to us?
Chairperson, the one which you've been just being handed in, it's a PowerPoint extraction of the main document which was sent earlier on. So indeed, there won't be any differences, but it's just for presentation's sake that I would want to request your indulgence on using this document.
Continue.
Can I carry on or suggest something, Chairperson?
By all means, please do carry on.
Good afternoon, and like as I've already formally introduced the Limpopo team, would want to heartily really welcome, the invitation to also talk about the experiences in Limpopo relating to how we are handling private facility applications. And Chairperson, the couple of pages on the document are more of, historic in the sense that they are telling the team in terms of where we are coming from, how many people are in there, and then in terms of, stats from South Africa, how many men and women, how many people are working there. I would humbly request through your permission that we take note of that information, and then maybe for the presentation, if you allow, Chairperson, but by the way, you can always still go back and during your interrogation to dig more. If we could immediately start looking at page 20, which is talking about, currently the beds which are available and in both public and private. I will be talking about the processes as I'm presenting, how we are, doing it in Limpopo. But if we could immediately look at that, Chairperson, that we have got 5,668 public beds in our, province. And then these are also related to what we call district hospitals. Other people will call them level 1 hospitals. And then comes what we call regional hospitals, which is level 2 hospitals. These are hospitals which are also having some specialists, general specialists. And then the number of beds available in our province is 149. And then specialized hospitals here, mainly we are talking about the 3, hospitals which are what is called mental health care hospitals. These are 3. And then the total number of beds is 1,576. And then tertiary beds, which are comprised of 2 hospitals. They are in 1 district in our province. And then the total number of beds is 1,210. And then private beds, you'll realize, Chairperson, every district we have actually tried to give information. The total number of beds is 925. Maybe I can quickly just mention that in Vembe, the northern part of our province is 44. And then Capricorn District is our hub in Limpopo. That's where Polokwane City is. That's why the number, the high number 493. And then Mopani is where Zanin and other towns are, 197. And then Sikukune, it's 44. I'm saying 14. And then Waterberg, it's 191. And then Chairperson, if we could immediately turn over to the next page that we have tried to just talk about, how many, or the number of hospitals and PAC, which is just for noting. I think we don't have to. Page 22, just a correction there, Chairperson. It's Limpopo Academic Hospital, not Sfakomagatu. Sfakomagatu is in Gauteng and the former George Mukari. Ours is Limpopo Academic Hospital, which we are currently planning to build. We haven't actually started with this. It's a national competency, and then indeed the plan is there. And then I'm going to just briefly note by bullet, and then talk about the process, Chairperson, how we are handling the process in our province. That we have got two teams, which the first team, we call it Technical Evaluation Committee. The second one is Adjudication Committee. And then when the applicant writes a letter to the HOD, then there is a form which we give it to the applicant to fill in, and then when that form is filled, and then it goes to the technical committee, which will sit there. In that form, just briefly, crudely, it wants to know in terms of warm bodies, human resources, the professionals and general staffing of that facility, and then where do you want to have that facility operating, and then why in that area you would want to have a private facility. And then once that is done with that form, by the way, we do actually technically say if you have scored less than 37 out of 75, your application will not make it through to the next level. The next level is when I would be actually saying you can start actually consulting your architects to start actually making drawings and everything, and then which you shall. After doing that, you send us that plan, and then men and women like Mr. Ramulai, in that technical committee, they look at your plan, whether technically it makes any sense. They engage with the applicant. If there are any issues which we need to raise as the department, we engage with the applicant to say, please, this line this way, this line this way, till finally, the application makes sense. And then after that, the next level, then the chairperson of the technical committee brings the decisions which were made during the technical into adjudication to formally present to the adjudication committee. Then the chairperson will be asked questions by the adjudication committee in terms of clarity through their processes. Once that is done, then and they are satisfied. In the absence of the chairperson of the technical committee, then a decision will be taken by the adjudication committee whether they agree with the technical committee or not. Then after that, then the process would be taken to the office of the HOD. Now, Chairperson, you'll realize I was not going through point by point. I'm just actually, luckily, as a part of the process, not necessarily going through page by page, just describing the whole process. That now, let's take a scenario where now the decision is being taken. Now let's look at page 25, Chairperson. If the application is found to be of approval by the HOD, then a letter will be written to the applicant to say, you are permitted. It's a permission. I want to emphasize this part, because even the people who finally they get the letter, they still continue misinterpreting it, taking it as a license. The letter would say, you are permitted to plan, erect, and finally operate the facility as planned by yourself. And then it will be sent to the individual, hold it there, and then the next bullet, which I would want to apologize to the team through you, Chair. We did include what if the application didn't succeed for whatever reason, which, yes, is another process that we will still write a letter to say your application was not successful. We normally don't give reasons. The reasons are being given by the authority. The authority in this case is the minister who has actually delegated the authority to the MEC. And then when you appeal, then the reasons are being afforded to you that here are the reasons why your application didn't succeed. The commonest being, where you are applying is already chock-a-block. It means there are no available beds in the area you would have applied to. And then that is also the negative part, and even further to say you are allowed to appeal. And then yes, the appeal can be heard, and finally maybe politically a decision can be taken. We have got an example around Polokwane where a political decision was taken, mainly because of the outcry by the applicants. I can indulge you on that part if you would want to know more about what really finally happened. Then we take the process where now the applicant will now start negotiating with the municipality in terms of where they would want to have the site and everything. Yes, as the department, some would come and say the process on the other side, referring to the municipality, is just, damning. Is there any way you can assist the department? The only assistance we would do, Chairperson, is we would write a letter to the municipality to say, these people are working within a time frame. And then if you could assist, in terms of their request, not necessarily to push the municipality to allow them, but just to make sure that the decision is finally taken by the municipality in terms of demarcation, if there's a need of environmental impact studies and everything, so that they can do that part. But that, Chairperson, still remains a big challenge with some of the applications, which I'll talk to as pages go on. And then we let them actually start building. And then during the building, they build under the regulations of that particular municipality where they are actually going to operate. We come when now and then they would actually invite us and say we are now, at this level or whatever. And then time allowing, would go and have a look at the situation, whether they continue complying with the regulation R158. Maybe I could just request the chairperson to quickly, go to page 31. I'm sorry, I'm not going page by page. Most of the things which I've already said are captured on all those pages. And then if we could look at page 31, that now these are, privately run, facilities in our province per district, and with number of, beds which we have allowed them to operate. That Tabazimbi, Lepalale, it's in Waterberg and Bela Bela, and Swartlap Mine, and then Amanda Belt. All these are in Waterberg. Then Capricorn District also, likewise, like as I've already alluded to that fact, Chairperson, that don't be surprised to see so many beds. It's mainly because most of the beds are within Polokwane city itself. It's like, our Johannesburg. That's where a lot of private beds are concentrated in. And then with a total number of 493. And then Mopani District, we've got only 2 facilities which are run, privately, but the first one, Clinics Palavorwa, it's not a wholesome 100% private entity. It's a triple P, which I can talk to a bit about. But Medi Clinic, the name says it's 100% run. And then in Vembe, we have got only 2. This is around Makado. Makado is the small town in Vembe, formerly called Louis Trichardt. These 2 facilities are there. And then in Skukune, just 1 private small entity in around Groblestal, and that is it as far as Skukune is concerned. And then I've already spoken about, these are currently run private entities. But we do have applications we have received, Chairperson, some of them in terms of status, they have lapsed. Some of them, very few though, are still, carrying on in terms of finally developing. In Waterberg, Mogalakwena, the license, not necessarily the permission, has lapsed. Mokopane private, the permission has lapsed. And then Mokomet is still within Mokopane. This is formerly Pipiras, Potgieter's Rest Town. These have lapsed. Mudimule, private. I'm sorry, the capturing there is not showing. This has also lapsed, Chairperson. And then Capricorn District, Burolo private, it's within Polokwane, formerly Petersburg. 1, 2, 3, 4, 5, 6, applications. All of them have lapsed. And MedLab around Leboa-Khomo Township, 50 beds which were applied for. The application has lapsed also. Upelong Rehabilitation Center, the application also, it's on. We have just received the plans and everything. This one is still alive, Chairperson. And then in Mopani, the applications have lapsed. And then Sikukune, we did receive applications, you'd recall, in terms of previous available infrastructure which was run. It was only running at 14 beds around Groblersdal. Applications dropped in, and then we gave them a permission to operate, to plan, and then the application has lapsed, and which is Beggarsford Private and Platinum Health, both have lapsed. In Vembe, it's around Tohando. The applications were received, Honorable Chairperson, also lapsed, both applications. And that is it, Chairperson, with regard to the process in terms of for the status where we are. I must allude to the fact that we have received fresh applications currently, which we are going to have a look at, and we will make a decision on that. We continue assessing and then giving permission to the applicants as they qualify to plan, erect, and finally operate. I'm going to skip in terms of health personnel here. The status is known that we don't have specialists. There are very few and scanty. And as we receive more applications, especially like within Polokwane, when we ask the applicants, where would you get the specialist from? They keep on telling us that they are going to recruit from Gauteng, to bring those specialists. But we continue also in the process bleed with the few who will be there. We have lost quite key personnel when one of the facilities opened recently in around Polokwane.
Is the ability to attract specialists one of the considerations in applications for permission to operate a facility?
Chairperson, yes, they do, but not on a full-time basis, in the sense that they would now and then have a sessional work with them traveling from Pretoria, which is over 270 kilometers into Polokwane, not on full-time basis. But mostly, Chairperson, there are some specialists who are currently practicing as solo practitioners, specialists within Polokwane itself. So some of them, are really recruited directly into, those facilities. But like as I'm saying, we also as the department, we lose some key specialists. I'll give you an example. We lost, a radiologist, which was key and the only specialist then into one of the recently opened private facility, which is now and then beyond our control, mainly because of money. Chairperson, I would want to come to maybe towards the end, that is page 47, that we are realizing that our applicants don't understand the reason why they are making applications to run a private entity in wherever in our province. And we have taken it upon ourselves to make sure that now they start understanding that it's not just to say I'm having a private hospital in this, it's a business entity, but also us as Department of Health in Limpopo, we are looking at finally also benefiting. We may not necessarily have everything in our facilities. Private entities may have a, MRI scan, which we may not have in Limpopo. Our patients may benefit from that. And when an application which was permitted and it fails, it really, worries us quite a lot. And some people go to an extent, I'll give you a living example, Chairperson, that they would even go around with that paper, which is not a license, soliciting money from whoever. Maybe they may even come to you, Chairperson, and say, we've got a license, how about 100,000 rand? You become part of the deal. And it continues till it lapses, unfortunately. We were approached by IDC as a provincial government to say, we didn't have anything in writing, Chairperson, but this is what they told us, that they were mandated by Parliament to go out to start seeing how they can support the rural areas in terms of development. They came to our department to say, we hear now and then you are receiving applications, and then what happens to those people? And then we told them, that some of them are being assisted by the big three, as known, Life, Netcare, and Mediclinic. And even in some incidences, there can even be some bit of a muvango, because this person would walk into Mediclinic and listen to the conditions, and next thing walk into Netcare and listen to the conditions, and then decide who is the technical developer, financially and otherwise. So that is actually our experience. So we had thought that IDC was going to really assist some of these applicants. And we further again, as the department, advise all those applicants who might have succeeded in being permitted to plan and erect, to communicate with IDC in terms of financial needs and everything. Up to now, Chairperson, as you heard me just say lapse. And some of these people are the people whom I know we have actually advised them in, except for the big three, or even ordinary personal banks, we advise them to go and approach IDC. For now, we haven't actually found any application having been funded by IDC. There could have been other processes which we are not party to, as I apply for financial assistance with IDC and like, which may make me fail. But we had hoped that, as you have seen, most of our rural areas in Limpopo don't have these private facilities. The endeavor, the try has been the pay applications which we have already shown, but unfortunately, finally still, for some reasons, there's no success. The only success has been in around Lephalale, where Mediclinic has been operating for some couple of years, and then it has also applied to us to increase number of beds. As we all know that Lephalale now, is booming economically. Mediclinic requested for more beds, and then we allowed them. So, Chairperson, with your permission, I may have to, hold it here, and then I think engagement will be very, very important. With us as a team here, we shall listen and try our best to assist the system so that indeed we can finally assist the country. Thank you.
Yes, thank you. Now, have you had occasion to decline a permission to set up a facility because you were not satisfied that that facility would be able to attract specialists?
Chairperson, we usually are always, because the areas where the applications are coming, actually being looked at, are small towns. Being small towns, we always, think that, yes, there can be one or two specialists who may still go there. Like as I said earlier, that most of the specialists are not necessarily going to reside in the area. Will now and come on sessional basis, and like especially those who are actually practicing as a group. And then they would send this gynecologist to Polokwane to go and spend the day, and then servicing, and then interchanging. So we never lost hope. That is the reason why even when we are asking, how are you going to really get specialists from? And then there will always be this innovation that we are going to try and attract these specialists into the area.
But you've never declined an application simply because you were not satisfied that they would attract specialists?
No, Chairperson.
So the main problem appears to be the funding. Is that right?
I would say yes, Chairperson. And again, looking at historically, competitions within the business itself, where now, if like in the Palale Mediclinic is already there, and any application coming in, and in this case, obviously, it may not necessarily be Mediclinic because it's already existing there. Any other competitor may look at it and say, now, does it make any business sense for us to go and build another 100 beds in the area? Even if there is a need, there's always this fear of finally maybe not making the real business out of the area. So except for, like as I alluded to, within Polokwane, which is our city, or a bigger town, or a capital of Limpopo, where now generally it's seen that most of the people would afford private services in the area, but generally the fear of competition in the outlying areas will still also remains a challenge.
But outside of the competition, what other problems are faced by potential licensees?
The ruralness, Chairperson, and in terms of economic status of the area, like as I've alluded to, you look at Skukune area, not necessarily looking about Beggarsford, which is now also coming up. We are seeing a lot of applications. Maybe one day there will be a private facility, but the ruralness, which is also obviously directly linked to economic status of the area, threatens potential projects in our province.
The licenses that have lapsed, what are the reasons for that? Why have these individuals not proceeded with the operation of the facility?
Well, the experiences which we have, gained, Chairperson, is that one, experience of some of the applicants when they were actually applying. It was also almost becoming fashionable that maybe Hapula would want to own a private hospital in such an area, but the real nitty-gritties of finally making sure that the project, comes up remains a challenge. And that is where I think, the problem would lie. That the people who with us is more dealing with paper, but outside us now going to have to now operationalize this permission. That becomes a reality that many of the people, I guess I've already given an example, Chairperson, that it just becomes, an excitement that, we are going to build a private hospital in this area. But in terms of project plan, it fails because they don't actually now start thinking now what next and everything. And I would give a living other example, like a women group in around Polokwane, which we had given permission to really plan and erect. Instead, they were actually just moving around themselves, having meetings, talking about money and how much to contribute. And then before you are a member, before you are a director in there, time continues. And then till, unfortunately, the time allowed lapses. And the person would run away with the money. Unfortunately, people would still come to us as a department and say, we have seen this letter, which would be true. And we want to know where is Miss so-and-so, because she has run away from us with money. So it's really pathetic, Chairperson, that project plan and project management amongst the applicants is still a big, big, big issue. That is the reason why many times you find the monopoly of the big three, that I go there helpless. And then they say, okay, Hapola, you have got this permission, we give you 2%. I'm just giving an example, not necessarily that. We give you 2% of the entity, and that's it, will develop a part of us. And that is currently what has been happening, Chairperson. That the applicants, and that is the reason actually our first bullet on our under challenges that people don't understand the whole process. What does it mean and entails? How much is going to cost you just to build 50-bedded hospital? So it's just an excitement, and we have agreed as a team that we are going to have to start talking to some of these people, because they definitely, these applications which have lapsed, technically they qualified. We will be receiving fresh applications in different names by the same possibly people, and then they will qualify. But we now need to start making a way of teaching our people what does it mean. By the way, it adds value, like as I said earlier on, that when a private hospital comes up, we don't see it as a competitor from government side. That is the reason why when we were planning for 2010, we counted some of these private beds which were being planned to be built. Unfortunately, 2 projects couldn't make it.
And when you consider these applications, you do not take into consideration the ability of the applicant to finance the project, or the expertise of the applicant to operate a facility.
Our tool, Chairperson, which we've been using as a province, was not yet looking at the financial capability part. I must say, I guess I've already alluded to that fact that with all these experiences, and one big challenge is project plan within, actually by the applicant, which we shall look at and make sure that indeed these are people. But remember, Chairperson, in many of these areas, remain mostly rural. Those people who can actually have a good plan to succeed and everything, maybe amongst ourselves here, we are not even in those rural areas. I've just given two living examples. You know, group of women who are not necessarily, by the way, professionals. We are going to have to, IDC actually was actually prepared to start doing that, but unfortunately this part of communication just went into a little late last year to make sure that they are capacitated.
An applicant for a license, amongst other things, must have land on which to build the hospital. There must be finance to finance the project. And then the third thing is the permission to operate. Now, he can't get the finance until he has the land. And can't get the finance too until he has the license. Is that how it works? Is that the reason why there is no emphasis on you must have land, you must have the expertise, you must have the funding?
Yeah, agreed, Chairperson. And as a team, we have even made decision that, or as a department, not necessarily as a team, that in our assessment tool, the municipality shall make it in writing that yes, there is an identified land, other processes of finally demarcation and everything, we know it may take a little bit long, but as long as one, the municipality keenness to really assist in such kind of a project. Number two, with what IDC has actually approached us about, that we are going to have to now form a tracker. The applicant, technical developer, which will be also somebody finally even financing you and even managing that hospital, because it's not just building and seeing patients walking in and out. You need to manage that entity. The management part, you know, to see to it that you are part and developed into that level, we are going to have to kind of, you know, are showing in most of the applications. The few applications we had earlier on, in terms of, you know, technical stroke financial assistance, most of them, Chairperson, would immediately, you know, show that I'm partnered with a Mediclinic or I'm partnered with a care. In such a case, with history, we don't usually have a, you know, a query. But there will be these applications where now they don't immediately declare that I'm partnered with this group or whatever, which we shall actually dig deeper and say, who is your financier?
Does it concern you that you have granted many permissions to operate these facilities and yet these licenses lapse because of inability of the individuals to secure funding?
It does, Honorable Chair. Like as I've already alluded to the fact that when we were engaged with IDC, we have appropriately actually even referred some of the applicants, irrespective of the outcome, even before, by the way, Chairperson, of the outcome in terms of a technical evaluation of the application. We referred the freshest. Most of these lapsed, applications, we have referred them to IDC, which we were hopeful that they will be actually breaking even the monotony of the big three in those rural areas. What has happened between the applicant and, let's say now, in this case, IDC, we are not privy to for now. But we are not going to leave it because IDC approached us. We are going to want to know what has happened, even if they are not saying so and so failed because of this and everything, so that together we can see, how these projects can finally succeed. Like as I said, Chairperson, yes, as the department, we always look forward for some of these, projects in those outlying rural areas, where now a specialist would go into Skukune. Those few hours, we are also even agreeing that they can even assist us as government in terms of patient care, because they are specialists. We might not be having a specialist in that regional hospital at that moment. So we were hopeful that these projects really would make it, but unfortunately, they didn't. And to an extent that I can give another example, that around Twando, applications, only one application, we're looking at number of beds, let's say 100 beds, were available, and all were gunning for that. We could only afford one. We even encouraged them to form a group of themselves to finally make sure that this project, succeeds. Unfortunately, still, as I've already shown here, it never worked.
I understand.
Thanks, Judge. Thank you very much for the presentation. I just want to ask here, I'm referring to page 17. It wasn't in the presentation today, but it's your written submission. There is a table of health personnel. I think it's L. Are we there, Doc?
Referring to the written submission, not the presentation. I think we do have if you can allow me, we do have a slide on human resources. I'm just going to quickly page through. I hope it's the same. And then page 42 on the presentation, if you could, I'm not sure whether it's the same slide, Chairperson.
Please switch off. Yeah. No, my question is really a quick one around this. I mean, one of the things we're doing here, we're trying to confirm the statistics that we are using for the final report. And I couldn't help but notice that in your footnote here, going with the table here, you seem to rely on the South African Health Review for statistics about your employees. How is that supposed to work? It's a publication. It means it says PESAL, which obviously is the salary system here, but then or use latest information from South African Health Review of 2013 or 14. I mean, the question is, if the department cannot trust its own statistics and relies on a publication to get statistics about its own employees, should we be concerned about the reliability of the statistics that we're getting.
May I request Dr. Pingwan to deal with it, and then I would also talk to it, Chairperson.
Thank you, Chairperson. In actual fact, these are the statistics that we also, this is from our own PESAL, not PESAL sitting elsewhere. So like PESAL, we know that PESAL will show us that this facility has got so many medical officers and specialists and all that. So we drew these statistics from PESAL, our own PESAL, not something that has been done outside the province.
I wouldn't have a problem whether it's the national PESAL or yours. I suppose the question is about a publication, South African Health Review, relying on it. I would have imagined that to start with, they would have gotten the stats from you. But I suppose the question is, do you believe that the system is reliable?
Thank you, Chairperson. Yes, we believe that the system is reliable because PESAL is actually updated on a monthly basis. And with that information, it's actually the bodies that we're actually paying every month that we know that they are in the province.
Thank you. Going on to the issue of licenses. I don't know, when you say you do the licensing last, Doc, what do you mean? Is there ever a situation where whoever the investor is, can start with the construction before they have the license? It does make sense, but I suspect I didn't get you right.
Yeah, Chairperson, when we are saying license, it's when now, maybe let me say in Limpopo, we do also have a team outside these two teams which I've already alluded to. This third team is the one which we call it a licensing team. And that is the team when now you are done with brick and mortar, you have put in all the machines and everything, you have painted and you have recruited all the necessary warm bodies in the facility. Then they come and visit you. And they do real inspection. And after having been satisfied, then you get this license which you display on the facility, which every 12 months is being renewed. If something of serious material is found, we don't allow you to get that license. We actually request you to correct those mistakes which we are seeing, and then finally license you. I can give you an example about Netcare, which one of the latest licenses in the province that things were not the way we are expecting when we are doing inspections on you. Then they were not licensed to operate. They had to actually quickly deal with all those concerns, and once and finally give you a document, which is a license. The first one is permission to plan, operate, and erect. Once we have finally finished erecting and you have put machines and everything, and the system is ready like a car, when you start it, then we give you, that document which we call a license, which unfortunately is that, unfortunately, the first letter which HOD would sign, people immediately take it as a license to have a private entity. As you can see now, some of them have lapsed. They don't even have a foundation in wherever they wanted to build or whatever. Nothing. So that's why it's not a license, it's a permission, which is taking you to finally have a license.
Has it happened that a structure completely built and then you find that the department can't license, meaning that it stands empty, unused? Has that happened?
So far it hasn't happened, but let me allow Mr. Ram here to talk to, his finding. But where I am, we don't have any project which is still there because of serious conflicts in terms of infrastructure.
Thanks, Acting HOD. Currently, we don't have such a finding.
Is possible.
If it's possible, the issue is when we do inspection, if there are serious findings, then communicate those serious findings to the proprietor. That is so that they could be able to rectify issues as they are. But it's a collaborative effort.
No, thank you.
Yeah, maybe just as an addition, there are two types of licenses inspections that we conduct. Existing facilities or established facilities that are already operating, where we do the annual inspections and renew license. And then we also have for the newly built facilities. But so far we have not had an instance whereby a new facility has been established, and then when we do inspection, we find that they are not meeting, they are not compliant with all the requirements. It is not. But what we have had so far, if you look at the presentation, when it comes to Skukuni, the 14 beds that, if you see, we have put it under asterisks. The issue there was that the facility has been existing. So with the previous license inspection, we realized that they were non-compliant with a lot of issues. And they were given 2 months to address the issues. And when we re-inspected them after 2 months, we find that the conditions are still the same. The facility has not improved. And as a result, we were left with no option but to withdraw the license, which is, if you, in terms of the R158, is actually referred to as the certificate of registration. So we have withdrawn it. But we have also made provision for the facility that should they at any point find themselves having addressed all the issues that were raised, and they can write to the head of the department to request him for us to go and re-inspect and review that decision. There's also an appeal process that they've been given and all that. So this is the only facility so far that where we have withdrawn the license because of these gross non-compliant issues.
Thank you. We've heard here through some of the provinces that the R158 regulations are outdated. They don't cater for the needs appropriately. And Western Cape runs on a different sort of set of regulations now. As this morning we had Freestate. Is Limpopo satisfied with R158, that it's adequate for the purposes for which it's meant?
We are not satisfied, Chairperson. Not necessarily relating to the age of the regulation, in that things have moved on in terms of infrastructural, plannings and like, and I must actually inform the team that we have formally engaged National, that because this is a national issue that we need to urgently start looking at, revamping the R158.
you have turned some licenses down. I think in the what you've given us as I think what I want to know is that have you worked out how I mean in terms of each region, how many beds each region can actually absorb? How would you know when Capricorn is overtraded, for example?
Chairperson is we have turned down some applications as fresh as late last year or so. For some different reasons, I'll just quickly mention. One, you find that there is a permission already given to so-and-so, and this person is moving around, like as I've already alluded to, and also maybe negotiating with financiers and the like. And as long as people don't see the real struggle in that area, there's nothing. And then such applications will come in. And as the provincial department, we are even at some stage saying, is there a mechanism which we could employ to let people who are thinking of applying for a private entity in an area, to let them know that for now this is saturated. Please consider the following areas if you are still interested in this type of an activity. So we have actually spoken with our MEC about that. It's a matter of logistics. How do we really sell out that information? Where I am, Polokwane was saturated at some stage. And then with all these lapses, yes, technically we go back when we receive any fresh application. We look and say 3 applications had fallen off. This one is requesting for so many beds. Technically, is it within or just above or whatever? Then we accordingly do that. I can lastly, Chairperson, give you another living example where current Mediclinic in Polokwane had applied for extra beds on their current structure. We couldn't give them, merely because there were no more available beds. 2, 3 applications were already done, and we're expecting those projects to come up. Unfortunately, those projects couldn't come up, and then Technical Mediclinic, knowing that now most of those applications have lapsed, then they came and said, now, we are still requesting for these 20 beds. What are you saying? We had to give, because by that time then, number of beds were available. And then Mediclinic was allowed to add 20 more beds. But generally, yes, like as I've already alluded to, the fact that where you see all these lapsed applications is when now we were saying, looking at both private and public number of beds to be available, therefore this entity can succeed in operating. We do that. But unfortunately, for the reasons which I've alluded to, the project fails.
Last one, really, I mean, regarding the, also from your side, I mean, the issue of viability is important, but I do see, well, the projects haven't been taken to fruition, but it seems like there was permission granted from your side. But, I mean, is a 30-bed acute hospital really viable? I mean, do you have that in your mind as to, before you award a license, at least minimum levels of viability? Because as I say, I see a 30-bed acute hospital. I don't know, the little that I know, that it might just battle to be viable.
Chairperson, the beds there may not necessarily be referring to a fully fledged general hospital. It might be 30 beds for maternity unit. which we would say is viable and all that, and or rehabilitation center, which would say it's or psychiatric, specialization. Not generally that you'll find therapies for children, 7 for women, and everything is for specialization.
We were supposed to take a lunch break at 1:15. The time now is 1:30. My colleague have assured me that we won't go beyond 2 o'clock. So would it be convenient for you if we continue until 2 o'clock?
Yeah, Chairperson, I think we are ready to continue, mainly that we are going to fly out of Devon to Limpopo sometime late in the afternoon, 4-ish.
Your flight is at 4 o'clock. Well, we've got every reason then to continue.
With due apologies, Chairperson.
Thank you very much, gentlemen. The public-private partnership in Polokwane, we had a presentation from the private part of the partnership, and the point that was made was that there has never been a referral of a public patient to this particular facility. Is that correct? And if so, can you explain to us why?
Chairperson, I'm not sure, because the one in Polokwane which we are aware of, it's renal dialysis, and our patients are benefiting. It's one of the most successful triple P. My suspicion is that you are talking about Palabora.
Yes, you're correct. I'm sorry, Palabora.
Yeah, just briefly about Palabora, Chairperson, is that indeed we have gone into that partnership with private entity clinics, and unfortunately, in their part, they're expecting us to send every patient whom our next door hospital, which is about 13 kilometers away, could manage. Our looking at the partnership was on specialty. And for some reasons which we suspect as government was that they are running away from maybe liability. One, they didn't want to admit orthopedic patients, those ones with broken legs and arms. Two, they didn't want to, admit, we would say, patients who are almost delivering with some conditions. They saw that as a potential liability. And when we are looking at them, saying, like as I said earlier on, when a private entity comes in the area, our benefit would be actually tapping from the specialists who would be actually servicing that entity. But they were expecting us to send any patient who, whether you are just having ordinary diarrhea, just to give an example, then we may as well close our facilities as a government in that area. That is actually where the biggest problem started. Not that, by the way, I know I've been signing off some requests for payments. We do now and then send patients of need to that hospital, but we can't reach their target mainly because they refused the areas where I think they would be adding value in the area. You can imagine all the pregnant women who may not be, operated on by ordinary general practitioner in our hospitals, who need an obstetrician. But they say no. Then we didn't see any need really. But we are currently waiting for them to relook at these two area of services, that is patients with surgical or stroke, orthopedic needs, and even mothers who are pregnant who need an obstetrician. Once this agreement is done, I think the project will survive. And we are optimistic, and I think it made them to, I'm sorry to use the word wake up, because like as we are saying, we can't now send every patient working in, who's supposed to be serviced in Maputo Malaji, in the township, into that hospital. But we are currently to see finally how we could do that. Thanks.
It's good to have your side of the story as well. I just wanted to check two questions on page 42, again, that table of employment. Question 1 is, do you employ clinical associates, and where are they on this table? And then the second question is your community health workers. Your final column is annual cost per staff member. And I think there must be an error here, because otherwise these are the best paid community health workers possibly in the world, at $500,000 a year. So can we correct? Am I right that this is an error?
Yes, you are right. We will actually correct the payment here. Yes, we do employ clinical associates of very minimal. It's only this current year that we are also starting to train them so that we can immediately absorb them. We do have them in 2 to 3 hospitals, which I may not necessarily mention the names now. These are actually working in our district hospitals. They add value wherever they are. That is the information which we have got.
So, just for clarity, are they then captured under all other personnel, or are they missing?
Yeah, they are included, Chairperson.
The last question was, the first thing you list on challenges is, well, one of the things is that you bleed specialists into the private facilities and practitioners into the private facilities. You've also explained to us that the province is very rural, that the density can be a challenge for viable services. And the question is whether the department needs to spend a lot of time on thinking about hospitals, or is it something else that you might need that would meet your needs? For example, a very good referral system to actually move people from more peripheral areas to central areas where you do have capacity. And if the province is keen on or has the ability to, or if there are any obstacles that stop you engaging in different kinds of interactions or contracting with different kind of providers that are not hospitals, that could in fact meet the needs of the province's health.
Thanks, Chair. I'll just comment a bit and request both Drs. Pingwan and Dr. Ndambi to quickly talk about specialists in need province. But from my side, just to quickly mention that, yes, we are currently engaging groups or individuals, specialists, mostly within Polokwane city. There is already a group of orthopedic surgeons who have grouped themselves, and then we are engaging with them. The actually communication we have had with them is that because of what was earlier on alluded to in terms of now indemnities and everything. And they were looking forward negotiating that part. We are also starting to look at signing a memorandum of understanding per every grouping, because I can write you an indemnity letter. The day you go away from Limpopo, that letter is gone. So we are going to have a memorandum of agreement per group of specialists, so that we agree with them when they will be trying to assist us in our hospitals. But in terms of recruitment, I'm going to request Dr. Ndambi to talk about the recruitment part, and Dr. Bingwani, if there's anything to add on that.
Thank you, Chair. Yes, we're a rural province, and it has been difficult, but we had put plans in place, and some of them had been working. And one of the issues that we're trying to do is to actually reduce the turnaround times in terms of recruitment, in the sense that sometimes, we headhunt. And when we headhunt, it doesn't necessarily mean that we do not interview. We actually look at the CVs, and we actually set up an interviewing panel as a matter of agency. But over and above that, we vet these people because we had bad experiences before, where people had come from our neighboring states, and they had actually, I think everybody knows what they do, and we had actually employed the wrong people. Now, the other thing is the office of the HOD had actually put up a team that looks at the people who are about to retire, and then they get assessed to see if maybe they can be given further contracts to actually continue to work. Now, as everybody knows, the doctors have families as well. So the other issue is that you see our timing of recruitment is important, because they need to move their children as well in terms of schooling and so on. So if we recruit in March, it may not be of good help, unlike if you start recruiting in July or August, where they can start negotiating for movement for their children to appropriate schooling. We have now put in place plans to target medical schools where registrars qualify as specialists, knowing fully well that they may not immediately get a specialist post, and negotiate with the specific professors. In particular here, we'll be looking at UCT, where, for instance, we'll negotiate that maybe specialists could be with us, even if it's a minimum of 2 years or so in rotation, as long as we pay them, and also to allow some of the registrars who will put on our payment roll to go and train in exchange at UCT or Stellenbosch or Natal or anywhere else, so that when they come back we can actually utilize them. We have been engaging with the National Health Department for this issue that relates to the following. When you draw up, or when you look at the OSD dispensation, where everything now is drawn to assume that things are normal, where you find the head of department is supported by a head of clinical unit and a junior specialist and so on, that is for the luxury of Tigerberg and Grooteskiel. We do not have that. You will find that the head of department is alone in the entire department. So the directive is that the head of department, in terms of overtime, can only qualify maybe for 8 hours. So we've been engaging with National Department of Health that maybe we should relax that part a bit, where it's informed by the volume of work that is being done. So if the head of department has to get up more often, comparatively speaking, a head of clinical department in Tigerberg Hospital, for instance, he should be compensated for, instead of 8 hours, that perhaps could keep them to stay with us. The MEC has actually instructed us to continuously engage with everybody who is a specialist, and in a meeting where she's going to be involved as well, in a way to try and retain those who are there so that if they have a problem or problems, they could be addressed as a matter of urgency. I think we are doing relatively well because I think a couple of weeks ago, Dr. Pinkwan and I had been implementing some of the directives as instructed by the department, and already in 2 weeks, I think it's this Friday, we'll be interviewing the first 3 very highly ranked specialists. One is an obstetrician and gynecologist, and one is an anesthetist, and the other one is a urologist as well. So it might bear some fruit. Thank you.
Yeah, maybe as an addition, we have formed a collaboration with UCT, with the Department of Internal Medicine, where Professor Mayosi is actually assisting us in training some of the specialists for us. Already, we are having a specialist that is training for us as a nephrologist. And this doctor, after he qualified, we're paying the salary and everything. So 6 months he's at UCT, is working, and then 6 months he comes to the province and assists. So we're intending to extend that collaboration so that we get more specialists, and also with other departments, as Dr. Ndambi has already alluded to. Now, the other thing that we have been doing, we're also having programs that we're participating in, like the UNV. We're having these doctors from United Nations, the volunteers, where there is an agreement that was signed by the late President Mandela and UNDP on the UNVs. They come, and then we mainly send them to our district hospital, the rural areas, and they actually provide quite a good service to those communities. We're also engaged in another Cuban program where the department is actually having a memorandum of agreement with the Cuban government to provide us with the doctors. Mainly, we do get those that are specializing in various disciplines, family physicians, and we have allocated them mainly to the regional and our district hospitals so as to address the issue of referral. I must say that it is a bit difficult to implement an ideal referral policy for the province because of the rural nature and the geographical location of some of the hospitals. Because you may find that in some of the districts, the referral pattern will not work because, like for instance, in Capricorn, there's no regional hospital. And the only hospital that is around there is a tertiary hospital. And the next is a district hospital, which is about 10 kilometers. So if we have to formulate an ideal referral pattern, it's going to create a lot of problems there. But however, we are trying to accommodate as much as possible, where we even provide different levels of care even in tertiary hospitals so as not to inconvenience patients. But there are those initiatives that we have already put in place. And the active recruitment is going on. Even as we were seated here last night, we were busy talking to some of the specialists like Dr. Ndamis. So there will be more that we'll be bringing in.
Thank you for your presentation. My first question is on the presentation. I think slide 35, you had in the Sekhukhune district, the certificate there was suspended due to non-compliance. Could you talk about in what areas were they non-compliant?
Thank you, Chairperson. The facility was actually having 14 beds, and they were licensed to provide maternity care and also to look after HIV/AIDS and TB patients. Now, when we inspected the facility, we found that it was actually one ward, which was divided by a swinging door that is leading from the HIV/TB ward into the delivery room, because just next to where there is a demarcation, it's actually the delivery room. And the issues that really affect, that were of serious concern were issues of infection prevention and control, and the cleanliness, found the dirty, policies were not there, issues of security, they didn't even have cameras or no security at the entrances, especially for children and all that. Even outside, the security was not adequate. And then patients also in the TB ward, there were no policies like, no ventilation, they didn't have standard operating procedures, found windows closed and all that. And some of the observations that we made, like for instance, one day we went there, they just delivered a baby the next door, and the nurse who just delivered the baby went to the ward wearing gloves, and she was touching everything, came back opening the door, went for the baby with the very same gloves. And we found those infection prevention and control practices very serious, because as part of our inspection, we put more emphasis again on the 6 ministerial priorities. And really, if things are not correct there, we really penalize the institutions. We did request the institution previously to say that you cannot mix HIV, AIDS, TB patients with freshly born babies. It is a very serious risk, and but they didn't correct it. Now, when we also went to other areas like the laundry, we found that they were just using these domestic irons, to iron linen and all that. Whereas, in terms of infection prevention and control, those were not effective. We expected them to be using those that will assist you. So there were quite a wide range of issues that we picked up, which we thought were very gross, and will compromise patient care if we don't suspend the license.
Thank you. My final question, on your written submission, you have outlined the licensing process to be, 3 phases. On page 10, one of your criterion for on phase 1 is whether the public institutions would be disadvantaged, especially by the attraction of rival staff and manpower. Having explained your difficulties in attracting specialists in your area, how do you apply this criterion?
I think the issue of bleeding in terms of staff is quite a difficult one, like HOD has already said. When they apply, they will be promising that they will be attracting staff from elsewhere, and we're not going to necessarily poach on you. But it becomes very difficult again when people send in their letters of resignation. We cannot stop them if they want to resign and go for what they call greener pastures. Like with the opening of this new facility, we lost quite a number of people, because I think what the private sector did, they put a very good a package for them to say, we give you a facility that is fully equipped and everything, you are not going to pay for a certain period of time and all that. And many people thought that maybe this is the opportunity for them to start with to go into private practice. And we lost quite a number of specialists from there, even those that we had that were doing sessions for us, like in obstetrics and all that, because there was this new opportunity now, decided to leave. Unfortunately, this is a process that we cannot halt. But we always try by all means to keep them within the public sector as well. But unfortunately, we cannot have much influence on what they finally decide. They want to leave. Unfortunately, there is no mechanism or no policy that we can use to stop them from leaving.
Thank you.
Dr. Gapole, I want to follow up on a number of questions that the judge asked you on the lapsed licenses. have you ever drawn up a report and doing some research yourselves on the background, on the, we talked about the IDC, about finance, about finding medical specialists, etc. Is there any report or hard sort of research been done in this, and can we have that?
Chairperson, our engagement with IDC is of recent, especially relating to most of these applications which have just fallen off, to an extent that that is the reason why I've already alluded to the committee that we are planning to visit IDC, even if they are not saying Dr. Hapola's application fell off because of whatever, but we would want to know and see the reasons. Like as I'm saying, we would want to see how some of these projects really succeeding. So for now, yes, we haven't actually formally engaged with IDC, and it's of our interest because we are seeing a different way of projects being carried out, especially in rural areas, which we are going to do as the department. Currently, still as acting HOD, it's my plan to make sure that that is done.
To make sure that I understand, but there's no comprehensive sort of research being done on the background of the elapsed licenses over the last 5 years or so.
No, Chairperson.
Thank you very much. You were here this morning with our first presentation, and also you alluded to the fact that also municipalities have something, or could have something to do with the fact that the parties can't proceed after they received a license from you. You even mentioned the fact that you go as far as send a sort of letter of recommendation to the municipality and explain to them how important it is to cooperate with this group that wants to invest. And also this morning we heard the same from the Free State, where sometimes municipalities do not cooperate. So I'm from that sounds really strange to me, because every province, I think, is also struggling with unemployment rather. And I think I'm from a country where if there would be a plan to invest in a hospital in a municipality, I think the mayor of the municipality would send out all the beautiful young women with flowers and try and welcome this company that would. What is the background? I do not really grasp what would be the background of municipalities not really cooperating with these type of investments.
Chairperson, this will be more of supposition, really, in this sense that when Hapola makes an application to Municipality X, is this person known in that area, in that community? Who is he and everything? I've got living examples within Mokopane, the Pipirast area, the town area, where a group of, sorry now to be looking like racialistic and whatever, I think I've got to say this, that a group of Indians with a few wives, they've been knocking at the municipality for some time, till now when now politically they've been joined by somebody else. We see some movement in terms of a resolution being taken by the council of that particular municipality. So this is the little experience which I've seen, that it also looks at your name, who's the applicant, whether you're known or not, even before looking at what you were saying in terms of the benefits to the communities. We look at the business part, who will be running this business and everything. Don't want to even go to some rumors, whether now what would I be getting and all sorts kind of things, which some of them they tell us.
So what you say, if I understand correctly, so political interest could trump the interest of the people that are being represented at municipality level?
Yeah, well, the area I'm talking about in terms of the municipal stability, there has been it has been there in the media that the mayor axes in today with his councillors. After 2-3 months, he's out. Then new mayor comes in and everything, finds some of those things. Those are realities, and unfortunate in that area. But generally, in the rest of the province, where now the biggest challenge is bureaucracy relating to the requests, that it takes long for council sittings and prioritizing such kind of requests vis-a-vis maybe the need of water and electricity in the area. So it takes long. But in that area, it was just unfortunate that we experienced such kind of setup.
Me to really understand. Thank you. So you are, Limpopo consists of 5 districts and 25 municipalities, isn't it? It is, so you could invite the municipalities in. You get them in a small room to these people on the importance of expedite these. Have you ever had that sort of discussion, please?
Chairperson, as a department about 4 or 5 months ago, that is sometime, let me say safely, late last year, we called all the departments in the in the province, all the municipalities, access health, to actually share issues which have got bearing on us. Unfortunately, that meeting was poorly attended for some reasons beyond us as the department. But now we have decided to take it on bilateral. We are visiting a department of education, sit with it, and finally we are already being a drafted memorandum of understanding, which is a product of Advocate Ramtopo. Finally, once we have sat with you and agreed in terms of where can we cooperate, intergovernment cooperation, then we signed that memorandum of understanding. Municipalities also included, Chairperson. So it's a process which is on now, as I'm saying, talking to you, that we hope some such kind of cooperation will come up. For sure, they are also expecting something from us as health also, which we could, assist. But definitely, by the way, we want to see some such kind of projects even coming through in IDP. Currently, IDP infrastructure is only relating to public stroke government, infrastructure. Where are you building a clinic, community clinic, and health center and the like? It's not yet including this. So during our engagement, then we'll be looking at some such kind of, deliberations to say you need to start recognizing type of activities as from health.
Thank you very much. Thank you, Chair.
Some of these licenses lapse because people have no access to land. Is it one of the problems?
Yes, Chairperson, I can give you an example around Polokwane.
Please do.
A project we called Borolo here, under Polokwane also, I know they've been battling to finally purchase land. Remember, I guess colleagues have already alluded to that some land would belong to the municipality. Mostly around these towns will be a privately owned land, and immediately you knock, you want to build a private hospital, the person would want a lot of millions, and that's where now the biggest hassle is. But yes, availability of land remains a big challenge.
That's a separate problem, but there's the problem of the processing of the building plans, the transfer of the land. Does that also lead to the lapsing of these licenses?
Well, Chairperson, we open our doors in this way that applicant X communicating with us, telling us the municipality hasn't set to take a decision on demarcation or EIA, and therefore, please extend. We do. And I've got examples where we now and then we give them 6 extra months to make sure that that process is done. We do that, Chairperson. Key is communication. They need to tell us that we are battling to get a land, or we have got a piece of land, but it's not yet formally demarcated by the concerned municipality. Please, we are still negotiating. We are requesting for extension. We do such kind of extensions, Chairperson.
The EIA, is that an environmental impact assessment?
That's correct, Chairperson.
Now, you have set out at least about 4 broad issues which you say are of concern to the province. One of these, and the first issue you draw attention to, is the urgent need to review the current regulation 158. This is at page 18 of your written submission. Yeah.
Oh, yeah. Thanks, Chairperson. Indeed, like I say, we have already mentioned during our presentation that yes, as Limpopo Provincial Department would heartily want to engage with National and see to it that R158 is freshened up.
Possibility is it to review the current regulation. Other provinces, the Western Cape has its own regulations. The Freestate, you heard this morning, they've got their own regulation which deals with the licensing of facilities. Gauteng has its own statute, although it hasn't come into operation. I mean, what's holding Limpopo from taking this initiative?
Indeed, Chairperson, I would want to take the concern as Limpopo. But rest assured, from where we have been, I think 2014, late, we were even called by NCOP for health on private licensing, which we actually mentioned it. Our approach as Limpopo, that's why we are saying we are actually engaging with National. Not that we can't do it, but we would want to be part in everything. The 3 provinces which have already taken initiative, we will actually benchmark on everything. But finally, where we are, a national document would be, standardized to avoid Limpopo doing its own and everything. That's why we are still living with, unfortunately, the old R158, but we are taking note that, and we have realized that that's why we have actually mentioned that we need to, urgently engage with National, and then there could be some plan which we could, yes, indeed, take whatever is currently happening and move on.
At national level, there is a legislation which was enacted in 2003. Some of those provisions have yet to come into operation. In particular, the very provisions that you're talking about, which will standardize the issuing of licenses, are not yet in operation. And there is no indication when these are going to come into operation.
Chairperson, yes, indeed. we agree with your observation. And like as I'm saying, we are not saying national, do it. We are saying, let's do it. And then we want to make sure that, yes, indeed, this project is done. It's not only this one, Chairperson, where now we have been engaging national on some policy issues, but we would always prefer to really, by the way, when we are saying national, it's us, even other provinces. So we are happy that other provinces have taken up an initiative, and then we can only see what is happening, and like there might be good things which we may take in, there might be things which they might have missed, and then we bring everything. That's the reason why we are talking about, standardization. But indeed, it's of critical, importance that, this regulation is nationally, reviewed. Limpopo can try and do here and there, but our looking at it is the entire country.
What I'm suggesting to you is that more than 13 years ago, there was a legislation was enacted. One of its purposes is to standardize the issuing of the licenses by entrusting that responsibility on the national government. Those provisions have yet to come into operation. An attempt was made to bring them into operation in 2014. But last year, that attempt was struck down by the court because there were no regulations 13 years later to bring these provisions into operation. The other provinces, in the meantime, have taken the initiative to address the situation. Now, my concern is that if Limpopo is going to stand by and wait, for how long are we going to wait?
Chairperson, we take the seriousness of the matter in this sense that as Limpopo, one, we will quickly, by the way, I'm talking here as acting HOD, which is going to make sure that the commitments are immediately implemented. I'm sitting here with the committee, chairpersons and colleagues from the department representing the province, that one, quickly within the next week or two, we will communicate with the 3 provinces and see how they are handling their issue, and then take lessons from there. Number 2, lastly, is that we will continue, like as I'm saying, when we are saying national, it's us, including other provinces. We will actually take initiative to make sure that nationally we do have, this regulation reviewed, irrespective that 3 colleagues have taken initiative, which we appreciate, and we are going to immediately benchmark on that and move on. Definitely that I can commit Limpopo Department of Health.
The forum at which you can raise this issue is the forum where the Minister of Health meets with the MECs for all the provinces at which your MEC is represented. You could speak to your MEC to raise this issue where all the other MECs are present so that the issue can be expedited. That's another option.
Definitely, Chairperson. The National Health Council, where the Minister, Deputy Minister, and the MECs are sitting, they are sitting with DG and HODs, which I'm part of. I will escalate it immediately after this engagement with DG, so that it's appropriately becoming part of the agenda item for discussion. And I will definitely raise the concern which Chairperson is showing, which is correct.
The other concern that you raise is finding ways of facilitating the servicing of the underserviced rural areas. As I understand it, is it about 80% of the Limpopo, which is areas? And how many people are there? The population that is there, roughly?
Chairperson, I would be, unless, we have actually classified, except for core Capricorn. Capricorn is around Polokwane majorly and like, with a little bit of ruralness, but the rest, I would say, is over 85% to 90%. That is rural. Even if we might be having a little light in small towns, which where now some of the applications are emanating from. But history is moving a little bit in terms of both Lepalale and Beggarsford, where currently a lot of mining is coming up. We are looking at it, the next couple of years, definitely economically, there will be a little bit of improvement. But it will just be an enclave. This economically, coming up area, just immediately you drive 5 kilometers out of Beggarsford, you are in the villages of serious poverty. So I would say nothing less than 90% Chairperson of ruralness in there.
And people who live there are entitled, have a right of access to healthcare services. And it's your responsibility to facilitate the achievement of that right in these areas. And do you have a strategy for that?
Yes, Chairperson, in both ways. Dr. Bingwan has just alluded to intergovernment, collaborations. Cuba being, number one in this one. That just about 2-3 months ago, we received 22 Cuban specialists. Out of that 22, I think only one specialist was actually left within Capricorn. The rest are sent out to these rural areas to go and try and close the gap, but the gap still remaining here and there. But the other reason is, the reason why we allowed these applications to go through, we are looking at it, that we can't afford, 25 or 5 MRI scans in districts. Private entities, can have that with their specialties visiting. I've already mentioned in terms of, there's such kind of collaboration that when specialist X visit this clinic in Toando or in Skukune, definitely patients in there of need will actually send those patients into that facility and then agree in terms of fees.
I'm not too sure whether you are familiar with this matter. There is an application or an initiative which was made in Limpopo, which involved a consortium consisting of a group of black doctors, Keystone Company, and Netcare, where they applied for, they were going to set up a hospital. Are you familiar with that initiative? Is anyone familiar with that initiative?
Yeah, the Chairperson, I'm aware of that. And that is the one which I alluded to, that when we were planning for 2010 World Cup, we were even counting the number of beds from that entity.
Who was, in whose name was the license issued at the time when this initiative was formed?
Chairperson, I can only recall the leader in the team. Unfortunately, he has passed on, the late Dr. Mabina. He was he was an ONG specialist, and then leading the entire team of black specialists. So when I was saying an application was politically, decided on, that time there were no number of beds, but politically it made sense for this group of people to, plan and finally operate a private entity. But unfortunately, it fell through cracks. The members started fighting amongst themselves, and unfortunately, in the process, we lost even the key team leader, the late Dr. Mabina, who was the project manager in that entity.
But at the time, the building operations had commenced, hadn't they? At least the foundation had been cut.
Yes, definitely, and we're looking forward.
Now, that hospital was eventually completed, is that right?
No, in the sense that totally a new application was looked at, which happens to have used the same site, which was belonging to the previous groupings.
That the application for a license in respect of those premises, did it lapse?
Chairperson, we are referring to the current project?
The hospital, the proposed hospital that was going to be built by this consortium of black doctors, Keystone and Netcare, I think it was.
Yeah, Chairperson, unfortunately, it lapsed, like as I'm saying, they disagreeing amongst themselves, and
a fresh license was issued in respect of the same premises.
A new license was issued, as the licenses are not transferable, Chairperson. And yes, I can allude to the committee that the same license used the same site.
To whom was the new license issued?
It's Poluso, Netcare, Poluso, Netcare or Netcare Poluso, but both their names are there, Chairperson.
Netcare had been part of the group that was supposed to build this hospital.
The first group, Netcare, was part.
Now, is there anything else that you would like to draw to our attention, which you had set out to come and talk to us about, but which you have not had the opportunity to draw to our attention?
Chairperson, I'm sitting here with colleagues. I've been engaged mostly with the rest of you. I would humbly, request them if there's anything they would want to say before I say it, because maybe they may not be afforded that opportunity. Through you allowing us, let me request colleagues if there's anything really they want to carry as a message to the committee.
In terms of reaching out to the patients who unfortunately cannot be afforded the medical care that they deserve, the province had embarked on introducing telemedicine that was actually set up on those areas that were far out. And the last active sites were 14, of which one of them, which was a pilot site, was a clinic that was sitting in Waterberg in an area where no one could reach easily in terms of consulting with specialists.
Yes. Thank you, Chairperson. About the review of regulations R158. Around the 7th or the 8th of April, the South African Law Commission met the department at Dilokong Hospital, where the Limpopo Department of Health and Mpumalanga Department of Health made presentations and raised the issues about the need for the review of the regulations. So, taking from what the Commission has indicated to us, we will liaise with the Law Commission and also contact the other brother departments and learn from them, and with a view of independently as a province look at the regulations. Thank you.
And I think you must understand that really, the real concern here is that the present regulation, which is Regulation 158, as you point out yourself, doesn't set out the criteria for the establishment of a facility. And the result is that people who are applying for a license, they have no way of knowing what criteria you will be applying. And the result is the granting of permits, which end up lapsing. So that's really where the concern is. Yes, thank you.
From me, Chairperson, if there could be a way of communicating with the big three, Life Care, Net Care, Mediclinic, looking at some such kind of needs only, not for, I'm sorry to say, to use this word, not necessarily for profit. We know they would want to make some money in the process, but let them start looking out there in the rural areas, not only concentrate in big towns and cities where we know obviously they will quickly open today and by Friday start making some bit of cash. Then provinces definitely will start getting some value. Lastly, the issue relating to national health insurance, that since this song is being sung, everybody is just thinking that now because I'll be guaranteed of some money of some sort, that better I have a private clinic or a hospital, immediately reacted and waiting for Dr. Mzwaledi to finally implement NHI. I think if we could remove just that part of notion and remember we are partners in healthcare services. We are not looking at private entities as enemies. We are seeing them as partners in making sure that life becomes better for all of us. Thank you.
Yes, thank you, gentlemen, for sharing with us the problems that you are encountering in Limpopo. We wish you good luck, and we will take into consideration the issues that you have raised with us. And thank you so much for taking time to come and make a presentation. And I think, Dr. Rapole, you can resume your surname the moment you take the flight. Thank you.